Great privilege to introduce our respected guest speaker, Dr. Sagar, Associate Professor, Department of Medicine, AIMS Bhopal, and is the Nodal Officer for Resource Center of Tropical and Infectious Disease, ART Center, AIMS Bhopal, and MP State Antimicrobial Resistance Technical Committee. His research specializations are antimicrobial resistance, antimicrobial stewardship program, tropical and infectious disease, and diabetes. He has contributed chapters in trauma and emergency medicine and ICMR treatment guidelines for antimicrobial use in common syndromes 2019. He has 45 peer-reviewed publications and more than 1400 citations. I welcome Dr. Sagar sir for opening session for day 2 of SPCon 2021 on diagnostic stewardship.
It's a difficult opening batsman, very difficult. You do not know how the pitch is, so there is a very possibility that I may be out in 0 run today. I will try to keep you look at me all throughout my presentation. I will concentrate as much as possible so that I will be on time. We all know the difference between the antimicrobial and antibiotic stewardship. It took at least 3 years to identify the difference by WHO. In 2017, the slogan of WOW of WHO was handle antibiotics with care, and by 2020 they identified the mistake and made it handle antimicrobials with care. And this year the slogan was spread awareness and stop resistance. So that's how we are here to identify the different aspects of AMR and AMSP. I have been given the topic of non-conventional antimicrobial stewardship. I will try to figure out a way how important the other aspects, excluding the diagnostic stewardship and the clinical stewardship or the integrated stewardship, what more can be looked upon. If you look at the various consumptions of antibiotic over different sector, growth promoter. So if you are sitting inside your campus looking at only animal health, it is not going to solve our purpose. The various domains has been well described, starting from diagnostic stewardship to clinical stewardship. My motto will be to look at various non-conventional stewardship, starting from the role of nurses to the role of HICC to the role of administrators. And when you move out of your comfort zone and to move into the extra institutional antimicrobial stewardship practices, the role of various other sectors be our most important thing. For example, the chemist associations of the state, the veterinary, the fishery, the agriculture, and probably one more important department we almost always forget about, FDA, Food and Drug Administration, is one of the most important department, which department has to be pitched in for our antimicrobial stewardship program. There are a lot of subdomains I am not moving into, but my basic purpose of this slide is unless otherwise you move out of your institute, you move out of your comfort zone to identify various other subdomains of antimicrobial stewardship practices, you are not offering a complete package. Most of the time, we move with the clinical stewardship to catch hold of an antibiotic policy of your institute and how to implement it. That is the sole motto of clinical antimicrobial stewardship. The hardliner, Dr. Nusrat, will be speaking after me, how she is doing the prescription audit and feed forward. Means the moment you start writing a prescription, somebody is there with a stick in his hand and to let you know that no, you are doing a wrong work right here. So he or she is trying to modulate you or conduit you in a better way how a antibiotic should have been written. That is not always possible. I always appreciate Dr. Nusrat the way she is able to do it. I am not yet, even if I've tried very hard, feed forward MSP or clinical stewardship is really difficult task. Various people try for restrictions for the formulary restrictions. Let it be colistin will not be available in various wards of the institute. Again, a tricky issue. Restriction to do restriction by a policy matter becomes issue. Most of the time, the various institutes do number restriction. I mean, nobody can write more than 3 antibiotics in one go in this part of the hospital. If you want to write more than 3, then there has to be a signatory of 2 or 3. So non-conventional, the issue is how can we do it? But my question is, can we afford not to practice non-conventional stewardship? I know there are many challenges to look for non-conventional. The concept is not okay to many. HICC, AMSP collaboration is tricky in most of the institutes. HICC is most of the time microbiology powered committees and AMSP are clinician powered committees. And to have a collaboration among these is almost always a issue. How to do prescription audit, feed forward, formulary restrictions, antibiogram, implementing the policy. Our doctors are only responsible for it, or we have to pitch in some more. The opportunities, if we do not do it, being in a teaching institutes who have huge downstream manpower, I mean the residents and nursing staff, and we have a definite cadre of leadership, then who else can do it? I will start with the role of nurses in a big way to come into the picture of antimicrobial stewardship in a non-conventional way. They are the largest manpower in any teaching institutes. They have a parallel structure. They have almost all the time, the nursing cadre is there in educational institute. They are dedicated staff, spend more time with the patient than the doctors. They are there with the patient since admission to discharge. There is always a crosstalk between different wards. I mean, when a patient is shifted from ICU to the ward, you do not know for how many days the catheter is, the central line is, but almost all of the time when they take over the handing over, they are aware. So it is foolish not to include them in a large way in MSP. I mean, 1 or 2 infection control nurses we all have, but I want to identify a way how you can pitch in the nursing staff in a larger way. Now, I would like to welcome my colleague, Dr. Anurag Bhai Patidar, who is working as an associate professor in Nursing College of AIIMS Bhopal. Dr. Anurag, please.
Thank you, sir. Good morning, one and all. So, with regard to the contribution of the nurses in the antimicrobial stewardship, so at AIIMS Bhopal, in collaboration with the clinicians, we have done certain activities that I would be like to highlight. So, our presence can be noted in this conference also, where our 4 of our MSc nursing students are also participating. So it shows the courage and motivation of the nurses that they are coming forward in this great endeavor that will be helpful for the mankind at large. So the nurses are involved in the point prevalence survey that was carried out at AIIMS Bhopal on the monthly basis, and in that the nurses at large were involved in the data collection process. They were having the antimicrobial seed, were going taking the round from ward to ward, and were gathering the data that were later on verified by the senior nursing officers there, and finally they were submitted for the analysis. Then the nursing audit for the antibiotics, for that we have prepared a sheet for the auditing purpose. Also, the feed forward that was given to the doctors about the result of the culture and sensitivity test regarding the antibiotic use in the particular area. and whether the after the lab report, whether the antibiotics prescriptions were reviewed or not, that were also taken care. Then in the similar way, feedback words were given to the patient, as the patient is the central in any healthcare activity. So patients were also provided the information that were helpful for them. And it was also the part of Kayakalp audit. So the related sheets and performers were available readily. Also, we were doing collaborative work with clinicians, like during the WOW, we identify the champions doctors. Like in other institutions, the doctors are identifying the nurses who are performing in better way. But here at AIIMS Bhopal, we did it in the opposite way. The nurses are observing the practice of the doctors, that who is prescribing antibiotic rationally, or with who is prescribing in less number or appropriately. And these were identified by the nurses, and later on during the celebration of WOW at AIIMS Bhopal, these champions were awarded in the presence of director. And also awareness among the nursing students, that are the budding workforce and the future of the nurses. They were also sensitized about the antimicrobial stewardship program. So this is the approval that we received from medical superintendent AIIMS Bhopal about the culture of cultures as a part of ICMR MASP network. And this is the antibiotic prescription and administration sheet that were utilized during that point prevalence survey, where we collected the data about the sources of the infection, the reason of the prescription of antibiotic, whether sepsis was there or not, that were on the basis of certain letdown criteria, and initiation of antibiotic with date and time, name of the antibiotic, what dose were there, and after that the culture sensitivity result that were also entered in that sheet, and later on the data were compiled. So these were the areas where these data were collected, and it started in the April 2019 itself. And for that purpose, we created a WhatsApp group as well. In that group, we added all the senior nursing officers because they were the point where the data has to be verified, which were collected by the nursing officers. And all the nursing senior nursing officers, like more than 50 participants are there in that group, and the live auditing of that can be undertaken with the help of that. So that is the collaborative work that was done at AIIMS Bhopal under the leadership of Dr. Sagar, khadanga. And in that, I would be highlighting that Mrs. Mamta Verma and Dr. Lily Podar, they are the nursing faculty there in the nursing college, and they were actively participated in that project, along with the microbiologist and critical care clinician. They all are there. So that was the study on impact of an antimicrobial stewardship program on targeted antimicrobial therapy. Also, we celebrated during the WOW week, where we identify the champion among the clinicians, and these champions, as you can see, the presence of the nursing officer here and the senior nursing officer, a large number or group is present during this celebration. That shows the enthusiasm and courage and motivation among the nurses, that how they can play their role in that. So here, this is the picture which is showing that a nursing officer is felicitating the clinicians and in the presence of Director AIIMS Bhopal there. So that is the purpose, that is the just the to acknowledge their role, or to appreciate them, to encourage the nurses that they are also important in the healthcare, not only in the healthcare, but in the antimicrobial stewardship program that we are talking about. So at nursing college also, the budding nurses, the nursing students, undergraduate and postgraduate, they were also sensitized during this week. You can see the presence of the nursing faculty here, and all the nursing students are there. And there we have having the poster presentation on that, and the winners were also felicitated by the director M. Bhopal. So take home message, I would like to reiterate that the contribution of the nurses can no longer be ignored. Our contribution is also very much important, as we are available 24/7 with the patient, and so many activities that has been also highlighted in the previous sessions that requires a close monitoring and the presence 24/7, because nurses are there at the time of holiday also. They can collaborate in a better way with the clinicians whenever they are not present over the phone or in case with any mean of communication. If the culture report is readily available on a day which is holiday, it can be communicated by the nurses. So if someone does not invite you, ask for it. It is not necessary that all the time the nurses will be invited to participate in the particular program. It's our role, our duty, because we are working in a family, just like as a family. So collaboration with the clinician must be bilateral. It should be reciprocate with each other. It is not like that the collaboration will come in one way. The research activities must be collaborated, involve the working nurses and involve the BSc and nursing students, inspire them. That will be very much important. They can have a very good presence in that program. Be true to your profession for infection control practices that has been largely undertaken by the nurses. And for all these, what is the requirement that we have to come out from our comfort zone? Then only these kind of activities will be successful. The results will be more fruitful. Thank you.
Thank you, Dr. Anurag. If you look at the role of nurses, you take any small measure, the lag behind time from receiving a culture report to prescription of antibiotic, the best person to identify that is nurses. Sending of cultures, garbage in and garbage out. Who sends the culture? The nurses again. So it's really important time to let them role model in our institutes and a part of the antimicrobial stewardship practices. He showed you a WhatsApp group where I have around 51 nurses. I receive hardly 5 or 10 messages a day from clinicians, but at least 50 to 70 messages from nurses that so and so place, so and so issue is there, try to solve it in some way or other. That is the beauty of working with nurses. Now I'm moving into the role of administrators. Yesterday we had a chart with Dr. Prasanna Panda, how important it is to take your administrators side by you. Many people tell to work with administrator is a bit of buttery, but it's okay to me. If it is buttery, to achieve a larger goal, it is okay for us. You have your own limitation. If you work 24/7, 365 days, still you can achieve less. But if your administrators are with you, you can achieve much more. There is always a crosstalk between the administrators at larger areas. Like if your director is convinced, Mr. So-and-so, Dr. Prabhakar is doing a good work, he will try to pitch in with other institutes, with other health officials, so that your role increases, your responsibility increases, and you are giving due credit to your job. Without their involvement, there can be no policy and there can be no implementation. So it's very important to identify the role of the administrators. I started way back in 2018. I invited almost all the big shots of the MP state, starting from the Director of Medical Education, Director of the Health Services, in presence of my own director, pitching in ICMR and WHO people online. So that's how the ball started rolling. Ultimately, what I could achieve is, with a lot of effort, at the end, within 3 or 4 months, my baseline data was already ready for AIIMS Bhopal, and we could identify a white document called Antibiotic Policy of the State of Madhya Pradesh. This was really important for me to have some sort of a policy for the state. There has to be advocacy. It has to be a people's movement. When the big shots speak from their mouth, the downstream responds to it. There has been a lot of advocacies by the upstream health officials in the newspaper, in the radio, television, and the downstream. All these are like district headquarter hospital champions who took to their stride how to go away with antimicrobial stewardship program, whatever mean they can achieve. If you look at, we identified around 500 statewide trainers who will go back to their divisional headquarters and train about the rational empirical antibiotic practice. I come from a state of Madhya Pradesh, whether you like it or not, culture facility is not available in a single district headquarter hospital, and there are 50 district headquarter hospital. I am pretty sure in Bihar also the scenario will be similar. So if we are talking about only culture, diagnostic stewardship, integrated stewardship inside an institute premises, we are not doing justice to the larger picture that is lying outside the institute. Downstream, we trained about 1,000 doctors in the state. All are from the district headquarter hospitals. We carried several workshops online and offline in 2019 and 20. These are the pictures at various places. I could also try to pitch in the private sector. You know, only 30% of the people in India, they come up to a government sector. Most of the medical facilities or the medical prescriptions are from private sector. I tried to rope in the private nursing homes for that matter. As a blanket communication from the government of Madhya Pradesh, we identified 11 nursing homes across the state, and one letter goes that somebody is watching you. Once somebody tells you that somebody is watching you, 10% or the 25% war is won. Then we identified 3 nursing homes from 3 bigger cities, and we are surveilling their data. We are training them. We are teaching them how far you can identify the empirical practices and how definitive antibiotic therapy helps in the practice. I have tried to rope in the pharmacy association. Pharmacy association is a difficult task to achieve. Again, the same principle, communicate through the health officials of the state who has control over them, and try to some sort of advocacy for the pharmacy officials. Now, in this vow, the pharmacy association has okayed that they will put up a poster in all the pharmacy that antibiotics are harmful if they are not prescribed. So a small measure, but it will have a large impact so that the people will not go and ask for antibiotic. There should be a prescription for getting antibiotic. We can't undermine the veterinary sector. Again, it was not under our control. I had to write to the health officials of the state, then to the health officials of downstream. They wrote to the MP Government Veterinary Association, and now they have come under our domain. The good thing is that we have identified the champions in the veterinary sector. We have identified 50 nodal officers, each from one district. We had some sort of sensitization. You know, in human health, there is some sort of documentation, what is rational and what is irrational. Veterinary is largely unregulated. Nobody knows what to do. Even any antibiotic, starting from Mero, Coli, Imipenem, everything is available in the market, and you know about the size of the animals, and it goes unregulated, uncontrolled. Unless otherwise, you come in a platform of the to a national platform, the funding and other issues comes. like Dr. Prabhakar was telling yesterday, all this zeal and enthusiasm settles down after a year or two. For that, you require manpower, you require some amount of funding for it. We tried to rope in through the state of Madhya Pradesh, government of Madhya Pradesh, to activate ICMR, WHO, National Health Mission as such. And now we are getting funds for AMSP activities. This is the activity in collaboration with NCDC and WHO. He is the Dr. Sujit, head of NCDC, and this person, extreme right, is Dr. Anush Sharma, the head of AMR division of WHO, with whom we tried to identify a white paper called as Madhya Pradesh State Action Plan for containing antimicrobial resistance. If you look at the downmost picture, it has been jointly developed by 6 different departments, starting from animal husbandry, agriculture, fisheries, medical education, labor, and all. And some sort of a Bhopal Ghoshna Patra has been signed by all the ministers of the state that, yes, this thing has to be done as priority. Madhya Pradesh is the second only state in the country to have its own antibiotic policy after Kerala. And I came to know that this year, Delhi and Rajasthan has also come out with their own state action plan. You know about the Go Blue Day in this wow, 24th of November was a Go Blue Day as called by WHO. So you should, what I tried to do is with WHO, we organized a workshop where we went blue, and downstream the first picture, the whole of the NHM of the government officials, the awareness program started rolling down. What I could achieve in last 3 years is, in Madhya Pradesh, any scientific, medical education, scientific program, there has to have a session of antimicrobial stewardship practices. That is my contribution to the state of Madhya Pradesh over last 3 years. For example, yesterday we had a pulmonary medicine update in one of the medical colleges of the state. If you look at the, they are lectures, interstitial lung disease, multidisciplinary lung cancers, TB control in India, and there is one session of antimicrobial stewardship practices. So unless otherwise you pitch in large number of people across the state, our job is not done. So we have to think of different perspectives. Yes, it's really nice to have a or to work inside the premises of an institute, but this is our own institute. We can do some changes here, but who will look after the institutes? The community medicine people, the nurses, the administrators of the state has to be pitched in. Thank you. I hope I am on time. Yeah, I would like to take a couple of questions if it's there. Thank you, sir. Yeah, that is why I mentioned you the role of FDA. You are aware that cholesterol has been banned not from human health sector only. This has also been banned by the veterinary people also. So who will ban it? You can't do it. So there is a department called FDA, Food and Drugs Administrators. So you have to rope in them. We have already done it in Madhya Pradesh. We have identified how the meats and milk of our state are being regulated routinely. If you can Google, you can figure out the rate of or the percentage of antibiotics way back in 2017 and 2020. It's there in the Google, in newspapers. You can figure out a way, but that has to be done by FDA people. You have to rope in them by the state officials.
Thank you, sir. And regarding this involvement of the nurses into stewardship practice, that is a great thing, because while involving in hospital infection control, also that same problem comes. So empowering, next steps forward should be empowering our nurses for something which they know better than us.
Yeah. If you look at, in my institute, there are 300 faculties, 1700 nurses. How can you not take them into picture? So they have to be roped in. We are all the time talking of infection prevention control practices, but one infection ICN nurses or two ICN nurses, it is not going to enough. You have to empower them. They will let you know whether you are doing right or wrong, rather than the other way around, doctors telling that this particular nurse is good or bad or something like that.
For that, we also have to cut down our horns also,
Yeah,
because our egos and our horns need to be tamed down because of all this.
I could not have a WhatsApp group of all the faculties, but if you look at 51 areas of the hospital, all the SNOs are in touch with me. Each day, we are having some sort of communication. Any patient who have more than 3 days of any tube, I will get a red flag that so and so patient has a central line for more than 5 days. What should be done? Yes, ma'am.
Thank you, Dr. Sagar, for such a wonderful presentation. And we have been seeing how you have actually executed the One Health approach.
Yeah.
That is the most interesting point. And I totally agree with you. Unless and until we adopt that approach, we are going to reach nowhere. And just as a side comment, I wanted to say, it was in 2017 or 17, I think. Amrit was the nurse from PGI who made a presentation at AIIMS Rishikesh, and it's so enlightening to see that this conference we had 3 presentations from the nurses. So that's very
yes. We are moving in that line for sure.
Yeah.
And in the next conference, we would like to see more nurses roping in, particularly nursing colleges faculties should be involved. Let's invite them more and more.
And I think while we are talking about philosophical aspects, which are very important things to talk about, because behavior sciences are important way to address the change in behavior with regards to prescription, sending the cultures, diagnostics, everything. So when we're talking about these things, we are talking quite often about shedding our egos, which I agree is important. The thing that I want to say is that it's seldom the hardliners approach which helps. It's patience and perseverance which helps. One could be very strict, but it really is not able to deliver on the ground. And that's something we've learned from our chairperson of the committee, Dr. Gurpreet Singh. He would always mention, our work is to just suggest. Leave it at that. Let it sink into people and let them make those changes. Thank you.
Yes, ma'am. Somebody behind is asking something.
सर जो हेल्थ वर्कर है नर्सेज की संख्या जो होती है सर, रेशियो वो अच्छे ना होने के चलते भी अच्छा केयर नहीं हो पाता सर। अक्सर मैं देखता हूँ यहाँ पे, मतलब मैं भी यहीं पे इंस्टीट्यूट में ही हूँ, पटना में ही सर, और मैं या और भी कई हॉस्पिटल में घूमा, रेशियो नहीं ठीक होता है, नहीं करते हैं लोग। ये सबसे बड़ी लो दशा है, सबसे लो है इसका रेशियो सर, पेशेंट और नर्सेज का रेशियो।
फिर इसको कैसे ठीक किया जाए? देखिए, जो मैन पावर का जो इशू है,
पेशेंट सॉरी अभी बोलना पड़ा हमको, कैसे ऐसे बेड है पे, मान लीजिए 1:2 रेशियो है, पेशेंट को पोजीशन ही चेंज करनी है, पोजीशन चेंज करने के लिए आदमी नहीं देंगे नर्सेज। अब आजकल के वैक्सीन नर्सेज नहीं हुआ जो कंटिन्यू कर पाएंगे, एक इनके हेल्पर चाहिए, और नहीं मिलेगा तो स्वाभाविक है सर, ऐसे 12% 15 पेशेंट हैं। अभी कोविड में बहुत ऐसा खराब थी, हम लोगों ने बहुत मेहनत किया सर, मेल लोग थे तो किए। अभी 20:80 का रेशियो रखा था सर, जो है 20:80 में रेशियो में फीमेल लोग वैसे हैवी पेशेंट थे, मतलब ऐसा नहीं बोल सकते, फिर भी मतलब हैवी जो पेशेंट है उनको हिलाना थोड़ा मुश्किल था। 20:80 का रेशियो किया, नर्सिंग मेल थे थोड़ा वो सपोर्ट कर देते।
दिस इज ए वेल आइडेंटिफाइड प्रॉब्लम इन ऑल द हॉस्पिटल्स अक्रॉस द country. If you look at for that matter, the number of doctors and nurses training institutes have increased tremendously over last 10 years. पिछले 10 साल में मेडिकल कॉलेजेस, नर्सिंग कॉलेजेस के नंबर बढ़ गए. We are moving into that. कैसे रातों रात चेंज हो जाएगा कि हम अमेरिका जैसे बन जाए? ऐसा हो नहीं पाएगा. But we are moving into that direction for sure.
जी सर.
Yeah. Thank you. Thank
सब
you.
कुछ सर, नर्सेज हो और या और भी हेल्थ वर्कर, सबके लिए सर, सबके इंक्लूडिंग.
Thank you.
थैंक यू सर.
If there are no questions, I would like to end my presentations. Thank you. Thank you for your presence here.
Thank you, sir. Now I would request Dr. Asim Sarfraz, sir, to present a memento to Dr. Sagar Khadanga, sir, and Dr. Anurag Bhai Patidar, sir, as a token of our gratitude.
Stewardship Committee for PGI Chandigarh, and she has more than 150 publications and various chapters in books, and she is a founder member of consortium of dose optimization, and she also is a member of various committees related to antimicrobial stewardship at various levels. Now I humbly request ma'am to start the session on prospective audit and feedback.
Thank you. At the outset, I would like to thank the organizers. One thing that I really want to thank them about is the fact that they have been very perseverant about holding this conference for the last, this is the third session. So the last 4 years we've had 3 conferences, so that's something to feel very happy about. And the kind of presentations from the first conference to this conference have changed. So a lot of institutes have got active, and they're going beyond the domains of their institute. That's very, very encouraging. So what I'm going to talk about today with my team members is about post-prescription audit and feedback. And as you would have been able to make out, the person in the introduction slide was me once upon a time kind of a person, and a lot has changed since then. So anyways, the idea was that to make you easy. With me, I have with me 2 other colleagues. One of them could not come because of certain issues there back home. But I'll be introducing you to Dr. Ashish Kakkar, who works with me in antimicrobial stewardship, and Dr. Samiksha Bhattacharjee. The entire session we have planned it in such a manner that we are able to not just give you a brief idea about how we do it, but we actually make you do it, because time and again it has been communicated to me is that most of the people who want to initiate this exercise do not know how to go about it. So keeping this kind of communication in mind, we have planned this session. So there is a 7-step strategy. I thought I'll put it up here, and this has happened over a period of, say, 7 years or a little over 7 years of experience. So it's a summary of 7 years in 7 points, you could say. So first one is that I would say assess your resources, and most important resource that anyone has to assess is the human resource. You should have this idea about pooling in resources, So what are the kind of resources we consider as resources? These are residents, needn't necessarily be pharmacology or microbiology residents. Yesterday we learned from EAMS Delhi team how their ID residents are carrying out this exercise. So it can be a pool of residents from different settings. And it is a very good idea to pool in your resources. Make people join, because residents are going to move away. One important thing is, if they learn the good practices in an institute, they carry with them the good practices, and the effect that you have by teaching the residents is has a better impact than just concentrating on the faculty members. Yeah, I say faculty members are also important resources, but on purpose I didn't put it there. So to have uh, Dr. Ashish Kakkad or Dr. Nanda Gamad, who are my junior consultants in pharmacology, and Dr. Archana Angrup, for example, in clinical microbiology, is an asset, but that's a faculty resource. The other important resource is the nurses. And just before coming here, I was told by my ID colleague that I will be perhaps richer in some ways, because he's ready to share the nursing pool that has been assigned to him for antimicrobial stewardship work with us. So so that again is a very important resource, and I think I shouldn't be harping about it again, because Dr. Sagar has already elaborated it in great details, and honestly I just concur with him to the last minute about this important pool of healthcare workers who has the potential to play immense role in getting, I would say, not just our antimicrobial prescriptions correct, many other prescriptions correct. And third important source could, in many hospital settings, could be pharmacists. So basically, everyone should see what is available with them, because I don't see in coming future that we will be allocated a designated resource in terms of human resource for carrying out this activity. It would be good if it comes through, but I think till that time we have to work with what we have got. Second important resource, I think, is the digital resource. How much of your work is digitalized? And unfortunately, even in the tertiary care institutes which have come recently, digitalization, especially when it comes to writing prescriptions, is either non-existent or is minimal. Digitalization enables you in many ways. It helps you carry out your PPS automatically. I mean, we've been reading these wonderful PPS carried out sometimes even in India from corporate sector hospitals, other hospitals where there is a digital system of prescription writing. It is easy to dig out the prescriptions and analyze them. So what we do is, even we are not so blessed. So what we do is we developed our digital systems in bits and pieces. We are doing it, and over the period of time, for many of these activities, we have been able to have some digital resource there. But it is a very good thing if you have a comprehensive resource at the institute level or any healthcare level that you may come from. Second step is understand and prioritize the problems. When I say understand the problems, you have to have both an idea about the extent of the problem and the depth of the problem. If we consider any hospital setup or any healthcare setup or many healthcare setups as one unit, it is very wrong assumption. You have to understand that even within a hospital, there is so much of variety and there are so many different things going on, that to have one common method for being applicable within an institute is also a big folly. So how do you do that? One easy way is point prevalence survey, but you may call it easy. It is a Herculean task. Over the period of last 2 years, we've run 2 point prevalence surveys. One of them was a multicentric survey, and it required a concentrated effort from nursing department, pharmacology department, from hospital administration, from microbiology department, in terms of their infection control nursing people who were good at even reading antimicrobial prescriptions. So it is a huge task, but it gets over in 2 weeks' time. but you could run small point prevalence surveys in small units. That will give you about a broad scope of the problems in that particular unit. But that's not enough. You need to understand the nuances of the problem. So the way to go about it is work in the unit. For any unit for which I have to have a policy and intervention approach, I have to be working in that unit. For example, over the last 6 months, I have understood where are the issues in transplant intensive care unit. Dr. Ashish is working with me in the disaster ward. And by working, I mean, you have to be there on the rounds with them. You have to be seeing the audit and feedback on nearly a daily basis to be able to understand where exactly is the problem. Because UTI may not be an issue in rest of the hospital, but in renal transplant, it may be an important issue. You will not invoke CMV pathogenesis in, say, main ICU, which has post-operative patients and medical patients, but you will have it in some place like transplant ICU. So that kind of understanding you have to have, and you get it only by working. So that's what I call, and I often talk about it with my junior faculty colleagues, is the flavor that comes with the working in that unit, that you get only if you're there on the ground. So what are the kind of problems we identify? These are the various problems. It could be something as trivial, but which has an important impact, as the prescriber not being able to understand the reason for which he or she is prescribing. For example, very early on, we understood that our residents were not able to understand the difference between empiric and prophylaxis, and therefore what was continuing as empiric, they were labeling it as prophylaxis. And we understood this was the issue in other centers as well. So those are the kind of very minute things you will understand. Then you understand that there are residents after residents who are saying we are giving imipenem because we were suspecting it to be a staph infection. I mean, that comes as a shocker, but that's the reality. Any inability to understand that the type of empiric antibiotics that can be used. So that's a very tricky thing, and that's where we concentrate very deeply. And I think that's what Dr. Sagar alluded to. And I think he also understood this issue after having seen so much of it. Then there's hardly any evidence which is from our area which you can apply to your area. So sometimes you even have to concentrate on generating that evidence. Guidance and policies which are tailored to the setting are seldom available. Then you understand that there is no system for utilizing available diagnostics appropriately. So those systems have to be taken care of. You don't need to consider antimicrobial prescription first. First, you have to get your culture sending and retrieval or lab sending and retrieval mechanisms in place, what I call as governance mechanisms. And if we look deeply, I think they are the biggest drivers of high-end antimicrobials in majority of our tertiary care institutes. Fear of HAI. I mean, we often have these orthopedics and plastic surgeons who tell us what to do, ma'am. Our turn for neck surgery is not coming. I place this graft with so much of difficulty. I have this fear of losing the graft, and the prophylaxis is getting extended. First thing is that you have to understand that this fear is real. Accept that this is real, and then you will be able to address it. Governance issues is something that I've talked about. This is just a glimpse of the point prevalence survey that we did with our collaborating centers. There were issues with that, but I think by and large, we were kind of relieved to understand it was third generation cephalosporin, which was still the most commonly used antibiotic in these tertiary care centers. So I think though it is not to be regarded as something as a relief, but we were expecting it to be something like carbapenems, and thankfully it wasn't. So then by the depth, I have this example of surgery ICU where we've been working for the last 5 years, and we've been working consistently. We had initial changes by just some modifications of dose and administration and little bit changes in the de-escalation processes. But when we realized that high-end antimicrobials were still continuing to be used high, and we understood it was because of HAIs that were required, and they were all rational. I mean, if somebody has VAP in our kind of institute, you just have an option of polymyxins there, either colistin or polymyxin B. So that's rational. But high-end antimicrobial use continues. So what we did was we adopted our dual strategy where infection control bundles were paid attention to along with antimicrobial stewardship. And there was another problem which had crept up about giving double cover for gram-negative infection. So with this a very intensified program, we could audit and feedback, we could bring down the redundant use considerably. Third thing that I say is have a tailored approach. So how do you have your approach tailored? You have your resources identified, you have your problems identified, classify them into non-nuanced and a little more nuanced. So I could just put somebody to see if there is a compliance to guidelines. If the surgical prophylaxis is compliant with the guideline with respect to the choice and duration. If double anaerobic, I just give a list of antibiotics and say if they are simultaneously prescribed, call it double anaerobic. This is non-nuanced approach. Then assessment, just let me know how many patients are there with more than 3 antibiotics, and then we'll address them in a feedback. Antibiotics for more than 3 or 10 days for a given condition or in a given unit, identify that. Incorrect dose or administration. The first year JR is usually, first sem JR is usually put on this task. Compliance to infection prevention control. If you have a good load of nursing staff with you, you can really build up on this aspect. The nuanced ones are the difficult ones. For that, you need some kind of a medical background. You need some kind of training in evidence base, some understanding of data and analysis, so and rational prescription. So the cadre of people who have this kind of training are the people who have just finished their MBBS, are down 1 or 2 years in their course of post-graduation. And for them, then we train them a little bit on assessment of clinical status. For example, pharma resident needs to know whether the patient is critical or not, whether there is, why is it important, whether we have time to wait for the culture reports or not. So we have made a kind of system for making them understand these aspects. So they have to be bedside to be able to learn these, and they can't be just left on their own. The consultant has to be there with them for some period, and then you gradually move away. For example, Samiksha can manage, now she is DM second year resident, and she can manage 1 unit on her own. This is the tricky part, and this requires a lot of training. So since the topic is not training, so I'll not concentrate in focus control. This is not nuanced. I mean, patient is not responding. There has to be some reason for that. And you teach them how to help your treating clinician think about more possible sources. For example, sometimes our audit resident is able to point out maybe there is a collection somewhere we need to explore it. That could be the reason for not no response being there. Alternative diagnosis, in a rush of things, people, best of clinicians, best of surgeons, best of everyone may miss out some things. And there you have to make your resident think on those lines. For example, they have been able to point out towards the possibility of PJP or dengue-induced encephalopathy and such things, which may sometimes be overlooked. So there is a need that can be done with somebody, I said, with the skill sets that I counted, medical training, with the evidence-based medicine training, and some kind of training in data, in the sense the person should be able to run the data of culture and sensitivity in front of him or her. Last 6 months, I haven't had staff in this unit, so there is no need to have vancomycin up there in the empiric escalation regimen. Yeah, so it has to be cadre based training. All these resources have to be trained. What are the different approaches you can have for training? You can have on-site online group trainings, and then you must learn to handhold for trainings. So here I show you one picture, which is a very favorite picture of mine. The person encircled in this picture is Dr. Aditi Pandit Rao. She was a senior resident. So she was trained back home in the department during the rounds, during the bedsides. It was training on work, and she could graduate to a level where she could, at the end of case-based discussions, even take care of bedside bite-size discussions, 5-minute brief discussions on topics like that. When we identify people are mistakenly labeling things as sepsis, when they're not sepsis, it is infection, but not sepsis. So there was a class on definition of sepsis, 5 minutes class. Now Samiksha is doing those classes. Understanding empiric, preemptive, definitive, these terminologies and their implications. So these are just 5 to 10 minutes small after class sessions, which we do there in the unit after finishing with the bedside discussion. And then Dr. Sagar would be very familiar with this picture here. He had requested our surgeons to talk to their surgeons, and we had Dr. Gurpreet Singh, who was the chairperson and head of the surgery department, and Dr. Vanita Suri, who's the current chairperson and head of OBG department, to talk with their surgeons and obstetricians. So training can be anything, you just think of it. Then the next thing is the form which can capture the information. So this is one of the earlier versions we have here. Samiksha will go into the details of the later versions. The information doesn't have to be just about antimicrobials, dose, purpose, all those things. All those elements which help you in decision making are required. So even your labs have to be there. Even your clinical status have to be there. I think we alone delve into those details. Then only can you give a feedback. I mean, otherwise it will be limited to dose and administration. That is very limited feedback, but you could start with that. That should be a good starting point. How do you do feedback? Paper, pen, phone groups, email, any format which works for you should be workable. You can do it at an individual level. You can talk to the consultant privately. You could do it at the level of HOD. Regular feedback in the entire unit could be carried out. Now we have dedicated sessions as part of training program in different departments. So there a lot of feedback goes. Antimicrobial Stewardship Committee meetings start with presentation of report where the nodal persons from each department and, if possible, head of the unit, and then attend. We tell them that you can get as many people as you want. We don't want to restrict the numbers. And we communicate to the institute's leadership, whatever works best. I mean, there is no single way to do something. So these are the various formats, and the one on the extreme right has been innovated by Samiksha in Surgery ICU, and she puts down her notes in the files. Suggestion from EMSC, she writes and she leaves it there. We tell them, do not push it down, just chew, let them chew it, because they have their concerns, let them chew upon it. One day it will show results. So these are the kind of feedback we give. Different kinds of feedback. I don't think I should be going into too much of details there. Yeah. And then when we understood that other institutes express concerns that rationality assessment may not be very easy for them, then jointly we started on working on some tools which we can share with everybody. And Dr. Ashish will give details about these tools, because that's a tricky part. So we have to now graduate to a level that we solve the tricky parts. And then this was a topic of considerable deliberation since yesterday. How do you convince the clinician? I say, start with a friend, start in one unit, let the word spread. It'll automatically spread, because you telling I have brought a difference in that unit doesn't help. The unit in charge telling his or her friend in the coffee room that after they've come, a lot of things have changed. So that has a bigger impact. If you can show benefit on any of these parameters which are listed here, it will be great, but they are difficult to come. You know, even after so many years, the one thing that we have been able to achieve very consistently is rational prescription. Though we have units, we have outbreaks where such achievements are kind of brought down again, but that will happen. You have to accept that these are the things that will happen. And I think that would be my concluding slide. I would like to end by saying that just suggest, discuss, shed egos, and then be on the ground. Because that's the way to go about things. You know, policing will not help. Proposing diktats will not help. What helps is working with them, working along, and being patient. So I would like to say human resources are the most important. Different specialties bring different expertise, rope them all in. Expertise may lie in diverse working groups, so have as many and as varied as possible. Good to have a core team, but welcome all. Do not treat it as an ad hoc project. That's very important because it is a quality indicator for your healthcare setup. So it has to be a continuous work in progress. So with that, I would like to thank you. We'll have a lot of question and answer sessions at the end of all the our session. And in the interest of time, please note down your sessions and please post liberally on those of you who are on online mode. Please use the chat box liberally. We will be scanning through the chat box and we will also like to address those questions which emerge there. And with this, I would like to invite Dr. Ashish Kakkar, who is junior consultant in junior NIAB, is associate professor in clinical pharmacology unit of the Department of Pharmacology. And Dr. Ashish has now single-handedly taken up the disaster ward of the Institute for Antimicrobial Stewardship. And he has been working with me in different areas for and helping us this antimicrobial stewardship program in various ways. So I think that should suffice for the introduction. Rest his work will speak and he will talk about this topic. I think.
Thank you, ma'am. So after this eloquent session and introduction to prospective audit and feedback, so I'll be focusing on the assessment of rationality of antimicrobial therapy. So after looking at all the elements which were discussed in the previous session, so we left out at the developing new tools and methods to help in the antimicrobial stewardship and program activities. So one of them is to how to assess the rationality of prescriptions and then what to do about that. So I like, normally I'll be showing you the content slide should be your first slide, but since we are short of time, I'll be jumping right into the contents here. So let me start by giving you a few numbers here. So you may be aware of some of them, but it's good to be aware of some of these numbers that let you know that AMR is not a future threat, right? It is something which is here and which is now and which needs to be tackled right now. So the first number that I'd like to give you is 700,000. So that is the number of deaths that are attributable essentially to antimicrobial resistance each year across the globe. And if we don't do anything about it today, this number is expected to rise to 10 million by the year 2050. So this has been quoted by a 2019 report by Interagency Coordination Group, which includes WHO and a couple of other UN agencies. And out of these 10 million deaths, 90% are going to be there in Africa and Asia, right? That is in the lower middle income countries. And what you need to understand is it's not just death, it's going to have economic consequences as well. By around 25 million people would be forced into extreme poverty because of this, because of rising healthcare costs. And there was this 2021 study which was published in Lancet Infectious Diseases by Klein et al. So what they did were, they looked at the pharmaceutical sales across 76 countries over a period of 15 years across 76 countries. So what they found was that there has been a progressive increase in the sale of antibiotics across the world. While for the access group antibiotics, this rise was around 26%. If you look at the curve for the watch group antibiotics, this increase over the period of 15 years was 91%. So the curve has been much more steep for the watch group antibiotics as compared to the access group. And if you look at the blue colored curves, they are much more steeper as compared to the other curves. So the blue one here represent the lower middle income countries. So the consumption of antibiotics is rising rapidly, and it's almost matching that of the developed world. So these authors did another part of their study was to look at the proportion of countries that were able to meet the WHO AMR target. So the WHO AMR target is that out of the total consumption of antibiotics in a country, 60% should be from the access group. So they looked at the performance of 76 countries. So India was ranked 75, right? So we were among the last two countries. If you look at the blue colored arrow, and still we had a significantly high consumption of watch group antibiotics as well as reserve group antibiotics. So among all these 76 countries, the consumption of antibiotics was highest in India. It was nearly 6.5 billion DDDs. So given, it may not come as a surprise to you given our population. But what's important to know is that this figure was 66% higher as compared to China, right? So that's a food for thought. So let's look at, so we've looked at the burden, we've looked at the cause. So let's come across, let's see what do we mean when we say it's irrational prescribing. So there is no universally acceptable standardized definition of what constitutes a rational prescription, right? So there are a number of definitions which are there, which broadly say that any prescription can be considered irrational if it's for an inappropriate indication, or if the agent is inappropriate, its dose, duration, or route is inappropriate, then it can be considered an irrational prescription. And there have been various surveys which puts a figure of about 50% of all antimicrobial prescriptions in healthcare to be irrational. So this is even higher, 60% there in the outpatient department. And as per CDC estimates, nearly 30% of prescriptions in the OPD which have an antimicrobial are completely unnecessary. So if you look at a recent data, so this was the survey which included 1,600 patients at around 200 US hospitals. And they simply looked at the prescriptions where the antimicrobial use deviated from the recommended practices. So they could find this in 56% cases. So major ones were community-acquired pneumonia, where they deviated from recommendation in 80% cases. In UTI, the deviation was for 77%. And also among cases that were using fluoroquinolones. And another group was where IV vancomycin was being used. So the idea here is that if you go and look for irrational prescriptions, it's not like you're looking for a needle in a haystack, right? So it's a problem which is quite common. So which brings us to the corollary that if irrational prescribing is so common, this means that the rational prescribing is complex, right? So it is a challenging task, right? It's an art. Writing an accurate antimicrobial prescription, it's an art, right? And people who could do it, they need to be congratulated for that, right? So there are a number of challenges when you try to prescribe an antimicrobial. That means considering the possibility of an infection, right? Considering whether it is community acquired or hospital acquired. So what are the local resistance patterns? What are the agent that you are suspecting? The dose of antibiotic, its duration, the route of administrations, its PK/PD characteristics, its drug interactions, the comorbidities. So there are a number of factors that have to be taken into consideration when you finally decide to write an antimicrobial for your patient. So it is challenging. And so moving forward, if you want to define irrational antimicrobial prescriptions, you need to have tools for that, right? Something which can help you objectively in identifying a prescription that needs to be corrected. So if you are aware of the current benchmarks or the current metrics which are used in antimicrobial stewardship programs, they include terms like defined daily doses. They also include days of therapy. So they are largely quantitative, right? So we don't have many tools which look at the quality of prescriptions, right? So So quality of prescriptions can be quite important, especially in our settings as compared to the developed world. For example, in the developed world, they have, it was discussed in the previous session as well. So they have electronic decision support systems. So they have these softwares which guide them on making prescriptions for their patients, and they are often linked to their electronic health records. So as compared to the situation in lower middle income country settings, so where the patient provider ratio is so high, the contact times are so low, and we often have a small set of antimicrobials from where we can actually prescribe. So as a result, having a rationality assessment tools in our settings can be especially rewarding and can be especially useful, right? So we not only can pick up problem areas, we can decide areas where we want to target our AMSP activities, and we can also look at the impact of those activities, such as the prospective audit and feedback, as well as educational interventions that were discussed in the previous session, right? So there are other tools which are available as well. The common ones include the Happy Audit tool, which is used in the UK NHS programs. So it is Hospital Antimicrobial Prudent Prescribing Indicators Audit. There was a study which was published in 2018 by Monier et al., where they defined 22 critical elements for defining responsible antibiotic use. So this was based on a elaborate Delphi protocol. But the more popular one is the one which is probably the earliest one. So it was published in 1973 in Annals of Internal Medicine by Kunin et al., and it's several other iterations have also been published. So here they basically categorize the use of antimicrobials into 5 different categories. So 1 and 2 are the ones which can be considered rational. So here the experts, they agree with the use of antimicrobials, and the dosing regimen is appropriate, or is it probably appropriate, right? So there are not major problems, and it can be considered rational prescription. Whereas 3, 4, and 5 are where they agree or they either disagree with the use of antimicrobials, and if they agree, so there is either a problem with the use of the agent, that is category 3, or they have a issue with the dose which is selected for that patient, so that is category 4. So since this method also relies on experts, it can be considered somewhat objective, right? So these are the limitations of some of the existing methods that we have. There are some other methods as well, but in the interest of time, we will not be able to discuss all of them. So with this background in mind, we wanted to develop a tool which can be used readily in our own settings and which can help our own AMSP programs. So we wanted to have a tool which can provide relevant, efficient, and accurate feedback in a timely manner, which can help bedside assessment of rationality and could provide an accurate feedback in a timely manner. So for this, we developed a tool. This activity was done last year. So we developed a tool and we piloted it at our own center. So this tool was called as Amaret tool. So I'll not be going into the details of how this tool was developed at our center. So, but I like to spend a couple of minutes on what this tool is actually about. So we have had several iterations of this tool, which has already been modified from the point where it was published. So this tool is actually it's like a flow chart. So which has several decision points, which will help you assess whether the antimicrobial prescription in question can be considered rational or not. So the first and foremost would be whether there is actually an infectious etiology at play or not, right? So the first consideration is whether there is actually an evidence of infection or not. If there is yes, so next is whether there is a possibility of a multi-drug resistant infection. So that would include other indicators as well. So this has also been modified. So earlier the question here was whether it was a community acquired infection or hospital acquired infection. But then we had discussions amongst ourselves and we saw that our clinical colleagues may not be able to directly look at that question in that manner. So they are much more interested in looking whether it is a condition that can be attributed to multi-drug resistant pathogens or not. Next would be, what are the reasons for prescribing antimicrobials? So was it spelled out, whether it is empiric, whether it is prophylactic, or whether it is lab-based? And if it was prophylactic, how accurate was the choice of agent and its dose and duration of therapy, right? So if it was empiric or lab-based, especially empiric. So we move forward here. We say that whether the possibility of sepsis or septic shock considered. So that would be based on the patient's clinical deterioration, if it is there, organ dysfunction, or you may look at the need for inotropic agents. And if it was there, so depending upon whether the sepsis was there or not, so as it was discussed in the previous session as well, there may be difficulties in deciding whether the patient is in sepsis or not, right? So again, that is another decision point that has to be made. Moving on forward, we also pay a lot of stress on whether samples were taken before antibiotics were administered, right? And then moving on further, we look at the choice of antimicrobial for empiric purposes here, and then we look at whether the choice of agent was accurate, the dose and the method of administration, if it was fine and as per guidelines or not. So next, we have now divided into 3 separate sections here. The second section would be where you review the antibiotics after 48 to 72 hours. So when the diagnostic reports as well as microbiologic test reports are available. So at that stage, you look at those results and you may want to modify your treatment regimen. So this question looks at whether these reports were reviewed or not. And if they were reviewed, were there any changes made in line with the reports, right? And then the new antimicrobial, it was selected or changed to whether it was accurate in terms of choice of agent, the dose, the method of administration, as well as the duration. And then we have a bottom section here where we look for possibility of source control, if it was there or not, and if it was there, was it taken care of? So this is briefly about the AMRET tool, which we have developed. So currently we have piloted it. So now we are in the process of validating it. So now, as we have discussed before as well, so we have made several iterations of this tool now. So what we are now working on is the AMRET 2.0 tool. So talking about AMRET, so I'd like to summarize that this tool was developed actually to assess rationality of antimicrobial prescriptions in our own setup, and it is applicable to other lower and middle income countries and either resource constrained settings as well. We piloted it in a group of MS personnel. So these personnel belong to different backgrounds. We had MSc pharmacology students, we had MD residents, and we also had a third group of DM clinical pharmacology residents. So the way this exercise was done was we selected a group of 30 prospective audit and feedback forms. The same set of forms was given to all the 10 raters that belong to these 3 categories. And they were asked to select a particular antimicrobial out of each prospective audit and feedback form and to mark whether it was rational or irrational. And if it was irrational, then what was the reason why they considered this to be irrational. And then their assessments were then matched with the assessment that were made by an expert group, which consisted of clinical pharmacology experts, intensivists, as well as internal medicine experts. So we looked at the agreement between these 2 groups of individuals, the one which were raters and the expert group. And we also looked at the sensitivity and specificity of our tool. So our tool had high percentage agreement for all the components, for the choice of agent, for its dose, for its duration, as well as overall rationality. And also we had good sensitivity and specificity as compared to the gold standard. So the gold standard in this case was the expert group opinion, right? Of course, this study had some limitations. So it was a single center study based on a rather limited number of forms. And we looked at a single antimicrobial. So its application in other complex situations, for example, where we have double antimicrobial covers or where there is possibility of drug interactions, it still needs to be validated. So we are currently in this process of validating this tool. It's in the form of a multi-centric study across 4 different centers in different parts of the country. So we are currently doing it, and hopefully once we get it validated, it can be useful for the different parts of the country which are interested and in launching and their own AMSP programs and using the rationality for providing an accurate feedback. So the ultimate goal of developing this AMRET tool is to provide a rapid and accurate feedback to the prescribers and to provide them with an advice which is of course actionable, right? So tell them what is the actual issue with the prescription, and it should be a versatile tool, right? It should not be a tool which can be done only by the physicians or the prescribers. So it can be used by people from diverse educational backgrounds, people with different experience, different levels of experience. So that is the whole goal of developing this tool. So ultimately, the thing why we did this was but because initially Professor Nusrat was like a one-man army, sorry, the one-woman army, as she likes to call it. So she was doing this 7 years ago, and she started from a single unit, and then she moved on to the second unit, and then the third unit, and eventually she also has two hands just like us. So they were all full, right? So she probably could not expand to other ICUs and other wards. So what she decided was she had to let go of some of the others. The ones she felt were probably well fed and could be functioning on their own, right? So then she moved on to the newer units, and then other people joined us like us. They joined her in her team, and then we could move on to newer units as well. So the idea here is to develop a tool which can provide a rapid and accurate feedback. So till now, what we have been doing is it's a two-step process, right? There is a personnel that goes to the ward, collects the data, comes back, and then we discuss them as a team, and then we provide a feedback. So it's a two-step process. So we want to actually make it as a one-step process. So where we can provide a reliable and accurate feedback right at the bedside. So it'll save us time and also will help us in providing our services to a bigger unit, right? So that is the whole idea. So that'll be all. Thank you so much. So now we'll move on to the hands-on session. I'd like to invite Dr. Samiksha Bhattacharjee, who's currently our antibiotic champion in the surgical ICU, and she has been womaning that unit for quite some time now, and she'll be sharing her experiences, and she'll be providing the instructions for this exercise. Thank you.
Good morning, one and all, and thank you, sir, for the nice introduction. Thank you, ma'am, for giving me a chance to come here and present. So, attendees, you are all with me, like raise hands, please. Who are with me? Because this is going to be a hands-on session. So, yes, ma'am, I know that you are always with us for this. So I will be, all of you has got your audit and feedback forms and the case summary kind of thing. Who have not got, please raise hand. All of you have, right? Okay. So, okay. Yes, so online attendees, those who are attending from online, the organizers must have mailed you the previous evening. So you can open that. I think I'll first show the audit and feedback forms, how it looks like, and then move on to my presentation. It's visible. Yeah. So, this is how we have designed our audit and feedback form. This is the most latest version what you have in your hand. So at the first place, you have all the description of the patients like IDs and age, gender, everything. Then it will have a previous history of hospitalization or not, and the diagnosis. If it is provisional, then provisional or definitive. Then it will be like whether patient is on sepsis or not, or suspected sepsis, any comorbid illness, history of antibiotic use, like there is any previous history. If patient is hospitalized at any other institution and came to you later, then what was the antibiotics used here? This will be in this place. Then moving the next section will be the antimicrobials administered at your institution, and antifungals. The next session will cover the microbiological, serological, or other diagnostics as appropriate. Mostly they will contain the culture reports of various samples. And next section will have your patient routine information. Here routine information will cover the basically the lab investigations, including the total leukocyte counts, temperature, procal values if there are any, serum creatinine, ionotropes, if any patient is attached to any devices, respiration rate, and clinical status. Clinical status, here you have to write it like we have 4 categories: same, worsen, improved, and death. So we have 4 categories, that is called SWEDE. And the next section is about the suggestion and the feedback what we give as from our side, the according to the date suggestion and whether it is followed or not followed, and the final clinical outcome of the patient as we follow the patient. So this is kind of the form what you have got in your hand. And I have also mailed you and the online attendees. And here the offline attendees, you have the case, one complicated case of a complicated intra-abdominal infection with you. We have given you the summary of a case report, and you have to go through the case report, and you will get 5 minutes of time. By then you will have to fill up this audit forms. So by the time you fill up this form, we will look into the presentation of the case. Okay. Is it fine? The instructions are clear to everyone? Okay, thank you. Okay, so this is about a case of complicated intra-abdominal infection, and this is the most common presentation what I find in a surgical ICU where I work with. So this is about a case of 55-year-old male. He came to surgery emergency on 28th of August, July, and with a history of pain abdomen in the right and left lumbar region, which is of moderate to severe intensity and which was relieved on oral NSAIDs. He also had a fever for 3 days, which was intermittent in nature, and it was also relieved with paracetamol. The maximum temperature shoot up to around 102 not. He also had a history of constipation for the same duration, and no other significant positive history like nausea, vomiting, or abdominal distension was present for this case. On physical examination, he was pale, and at the time of the examination, his temperature was 101.2. There was no history of icterus clubbing, lymphadenopathy, cyanosis, or other positive findings. His pulse was around 120, so there was a definitely tachycardia, and BP was around 100 by 70 millimeter of mercury. His respiratory rate was around 18 per minute. And systemic examination revealed generalized carding and rigidity all over the abdomen. So you can see it's a pictorial description of that. On follow-up, the patient was investigated with radiographic investigations, which confirmed the presence of pneumoperitoneum. So pneumoperitoneum means the presence of air, as you must know. That means there must have been a perforation. So the site of perforation assumed to be the ileum or ileocecal junction. So this was kind of a presentation of the X-ray. He was immediately taken into the OR, and he was immediately operated for the perforation. So we have the details and findings of the procedure, which is also written in the summary given to you. So this procedure was done as emergency laparotomy with an omental patch repair. So the findings during that procedure was there was a 500 ml biliopurulent contamination, and the perforation size was 2 into 2 centimeter. As a procedural part, the margins were freshened up. Primary repair was done with omental patch. Subhepatic and peritoneal drains placed, and empiric antibiotics started before incision. So here you can see that there we have to consider the portal of entries also. From now onwards, we'll remember that there are 5 portal of entry by which the infection can get through into the patient's body. One is the patient is on a ventilator, the patient is intubated. The second is a patient has a central line. 2 subhepatic, one is subhepatic drain, and another is the peritoneal drain, and one urinary catheter. The lab investigations and clinical findings of the patients is given in this table. So we have monitored the patient from 20th to the 29th as far as he was in the surgical ICU. And so you can see the trend of the counts, the total leukocyte counts, platelets, temperature, procal at whichever date it was done, creatinine, inotropes, and the clinical outcome, the clinical condition of the patient, whether the patient was same, worsened, improved, or died. So here, if you can notice, you have got the table with you also. From 24th onwards, the patient, the counts raised. With platelets, there was a dip in the platelets, and temperature, he was having consistent fever, continuous fever. The procal values were also giving a higher, like giving a rising trend, whereas the creatinine was kind of a normal throughout the course of his illness. And on 24th onwards, he had the increased demand of the inotropes for maintaining his blood pressure. So from this picture, we can clearly say that the patient was going into sepsis. We have got two positive culture reports of the same patient. One culture, the date sent was 28th, the day he was operated, and the sample was of intra-op collection of fluid, the 500 ml fluid that was collected. So that was sent for the culture, and the organism growth from that culture was E. coli, which was sensitive to piperacillin tazobactam. And we have seen that in our hospital setting, the E. coli strain mostly comes sensitive with piperacillin tazobactam and imipenem or carbapenems. And it was resistant to cefotaxime and amikacin. The blood from the central line on 22nd, it came sterile after overnight incubation. And we have a positive culture of 24th, which was from the sample of ET aspirate. And the organism grown in that was Acinetobacter baumannii, which was intermediately sensitive to colistin, sensitive to minocycline and tigecycline, and resistant to imipenem and meropenem. So this is the antimicrobial summary of that patient from the starting to the finally. So first he was administered piperacillin tazobactam. The dose is given as it is 4.5 gram TDS over 30 minutes. It was started on 20th and it was stopped on 24th. The reason it was given for the broad spectrum coverage of the patient in sepsis. The second antibiotics in this group was metronidazole, which was given 500 milligram TDS over 30 minutes, which was started also on the same day, and it was stopped on 23rd, and it was given for additional anaerobic cover because they thought that there is a biliopurulent contamination, so they need to have an additional anaerobic cover. The next escalation was done with the imipenem and vancomycin, which was started on the same date, 24th, that is 24th, because we have noticed that on 24th onwards, the patient was worsening and was going into sepsis. So there was also suspicion of ventilator-associated pneumonia because the patient was having new infiltrates on the chest X-ray. So they escalated the antimicrobials into imipenem and vancomycin. And lastly, the patient was on colistin, which was a lab-based antibiotic because Acinetobacter baumannii was found, which was intermediately sensitive to colistin. So now we will go for the what feedback we have given from our side according to the date wise, because we monitored the patient very closely and thoroughly. So we will start with each antibiotic and we'll assess what feedback we have given a chronological order. Okay, so we'll start from piperacillin tazobactam. We all have seen that we have started the patient on piptaz on 20th and it continued for 4 days. So the feedback we have given to them is dose correction, because piptaz, the corrected dose should be 4.5 gram IV QID and not TDS. For the infusion duration should be 1 hour to have the maximum beneficial effect. The next was antimicrobial was metronidazole. The feedback from our side was double anaerobic cover was not required for this case. So we suggested to stop metronidazole for this patient. The next antimicrobial was imipenem, which was escalated. The feedback from our side was given as escalation supported as patient was deteriorated and there was a suspicion of VAP. Because why there was a suspicion, so there was this many findings. One is difficulty in weaning of ventilatory support, inotropic support required to maintain BP, TLC increased febrile continuously, and there was also an increased requirement of oxygen. And of course, the chest X-ray images had shown new infiltrates with them. The next antimicrobial was vancomycin, which was also escalated on the same date, suspecting, and the VAP causing organism would have been an MRSA staff. So the feedback we have given in that to send ET aspirate cultures before changing the antimicrobial, and 24-hour report from the microbiology department what we got as a non-fermenting bacilli in ET aspirate. So it cannot be a staph. So we have suggested to stop vanco and start the colistin as a preferred choice for gram-negative MDR organisms. So based on our feedback, the colistin was started, and we have also have a confirmed final report for Acinetobacter baumannii, which was intermediate sensitive to the colistin. And we have also at this point suggested the addition of nebulized colistin. So colistin nebulization was also added to treat VAP. So with this, we have also suggested from this point continue for the 7 to 10 full completed days for the treatment with colistin. Additionally, we have suggested for drain care, central line care, bed sore control, and our residents who are posted in surgery ICU ward, they have make sure that they have asked about all these things to the surgery residents, that whether these things are taken care of or not. So on 26th, there was some delay in de-escalating vancomycin. We suggested them at 25, but there was some delay in de-escalating vancomycin. Sometimes it happens due to there can be a systemic delay. Because from our side, we residents, they communicate to the junior resident or the senior resident of the surgery. Now this communication had to escalate, like it has to reach to the consultant or the treating physician or treating surgeon in charge of the patient. So there happens a 1 or 2 days delay in de-escalating, especially the antimicrobials, which is acceptable. Next, 29th, there was 48 hours timeout we have given to the patient. We had done reassessment of the patient after 48 hours, and the patient responded to colistin. On 3rd, patient improved over time. His VAP resolved on serial X-rays, and he was shifted to the general surgical ward on 9th. So we had here how a prospective audit and feedback have helped the physicians and surgeons to make a successful recovery of the patient. So this was one of the keys. So this is audit forms and feedback, how we give in that. So as ma'am mentioned, that it can be verbal, it can be through WhatsApp groups, or it can be through any other channel. But what we mostly follow is, this is the antimicrobial audit form, and we write whatever our suggestion in the backside of it, what clinical suggestion of we are giving. And then second is at the case sheet of the patient in the ward, which is attached to the file of the patient. And here we also write the AMSP suggestion as, for example, here it's written that Acinetobacter is intermediately sensitive to colistin. So patient can be shifted to colistin. And we also advise them to give a loading dose of colistin and with a maintenance dose, and repeat cultures before changing. So this is the entire feedback how we give to the, how it is followed in the surgery ICU. So the general condition of the patient was fine on discharge. So the surgery people have asked that whether we should give any antibiotic on discharge. So the patient was febrile and the infection of intra-abdominal infection and VAP also resolved. So we advised no antibiotic for this patient on discharge. So the keynotes of this case to be taken as, we should always consider the local antibiogram and follow the institutional antimicrobial policy. Focus on the rational escalation, de-escalation of antimicrobials, monitor clinical signs and laboratory parameters along with serial cultural sensitivity reports, emphasize on source control, measurement of sepsis bundle performance. So these 4 points are the keynotes of doing a prospective audit and feedback. So sir has already shown you the AMRAD tool. So this is the tool for this, this is the entire tool. For this case, we will consider 2 antibiotics. One is piperacillin tazobactam, which was given empirically for this patient. We will see, we will assess this antibiotic, whether it was given rationally or not. So first, I think it's visible. So first step is, was the possibility of an infectious etiology considered or documented? So it will be yes, because the patient had an intra-abdominal infection and signs of infection. He had fever and guarding rigidity on admission. And then with which will be following this, the patient had one problem with the piperacillin tazobactam was the dose. So where we have corrected. And the next antibiotic will be imipenem. For the imipenem, where the antimicrobials reviewed in the line with diagnosis reports or clinical finding. So it will also be a yes, because the clinical finding suggested that patient was going into sepsis. And were the revised antimicrobial correct with respect to this? So this was a rational escalation regarding imipenem. And lastly, in that tool, we have about the source control. So was any source control applicable? This will also be a yes to it. And this was done by the surgery resident for this case. So this was all from my side. And thank you for your attention. Thank you so much.
Was on piperacillin and metrozil.
Yes, sir.
You told them to stop metronidazole.
Yes.
Did they listen to you? Number one.
Yes.
They listen.
Sir, that's what I said. Sometimes there might be a delay, but with this continuous efforts, we have actually cut down the number of double anaerobic coverage in the surgical ICU.
So
let me
with
tell you
with
that-
her intervention, metronidazole was stopped.
Sir, in fact, you would be glad to know that it was a universal practice in
Yeah.
2014-15. That is wonderful combos of piperacillin, tazobactam, and metronidazole, imipenem, metro. These were classic combo packs that used to come. And over the period of time, we have been actually able to bring it down. We have occasional spurts, but then immediately we try to get it back.
That is one of the most neglected part of antibiotic usage. Second thing is, Bhanko was added after development of VAP.
Yes, sir. There was a clinical suspicion of VAP.
You told to stop that.
So no, there was, I'll show you. So there was we had an additional information from microbiology side.
Non-fermenter was grown. That
Non-fermenter.
is why you
Yes,
told.
yes.
Can you just let me out to know what is the MRSA rate in your surgical ICU among the population of VAP? Any idea about that?
So, ma'am, would answer that. Yeah.
So for that comes from one of the ICUs, which is the trauma ICU, would have that as a positive agent. So then when we track the patient and we know that the patient is probably taking the route and has had intervention in an empiric, in case of septic shock, we will go ahead with the combination regimen. We have still not removed it from the escalation empiric regimen because we do not still are we are not very sure about any other focus, including enterococcus from the intestines also being a possibility. It's only when we are sure that it is gram-negative non-fermenting bacilli that we stop. And fortunately now they are ready to de-escalate Vanco on these information as they become available. In one of the units within our institute where 6 months consistently no MRSA, we have removed it from the escalation.
My last question will be, I forgot the question. My last question will be, I forgot the question. Do you advise piperacillin 4.5 at least 4 times a day to all the patients or only in sepsis and ICU?
Serious recommendations 4 times a day. We even say 2 hours infusion, not just 1 hour infusion. Critically ill patients, most of them we would say 4.5 grams IV QID. So that would be.
My argument is just think about it. Obviously, the patient is sick. That is why somebody is prescribing piperacillin. Why there are 2 regimens? 8 hourly and a QID. Is it time to recommend to all the patients QID only?
So we don't do it in the wards. In the wards we won't do it. Everything is case to case. But all the recommendations, we had a lot of discussion on this. All the recommendations, standard recommendations say it as QID. Initially, though I continue to debate this at our level also, wherein we say that for TID dosing also our responses were much the same.
Okay.
But when we wrote down our guidelines, all the critical unit consultants, they agreed upon QID dosing. We do have exceptions. For one of my colleagues' father only, after considerable discussions, we came to TID dosing. We said, okay, because she was managing him at home, said the infection was largely said, let's see on the watch. But critically in patients, everybody has decided it as a consensus.
Thank you. A big round of applause for the PGI team. It's a wonderful job they are doing.
Before I take this question, I think I would like to entertain a question.
Thank you. It was really very systematic and nicely done. First, I have a comment to make. How quickly, as the team from pharmacology, with these feedbacks, let's say on daily basis, you quickly reach to these clinicians of various departments. Doing your work at the background, how quickly you reach to with your feedbacks?
Sir, for audit and feedback, we do it on a daily basis. So first, mostly I go with, if any junior resident is assigned with me, then otherwise I'll go alone. Then I'll see the case and whatever findings from my side will be there, I'll communicate to my clinical counterpart, whoever will be there at present. And the next day, whatever suggestions made, I'll follow it up with them, that whether it was communicated to the consultant during the rounds. Basically, they change or they escalate or de-escalate their decision about antibiotics during the rounds only. So I usually make sure that within 24 hours it reaches to the consultant.
A second comment Dr. Sagar was also pointing out. This is a time that we should think of how we are incorporating this, let's say, diagnostic stewardship. Citing this case only, you told that the rate of this MRSA in your setting is not that much. And to me, just ET aspirate may not be that much reliable in a patient who is developing a bad produce kinds of infiltrates or secretions, or many times you may not have that much secretions to do anti-aspirate. So that is not very reliable. So in a setting where you are in a dilemma, and even if you have some growth like this, anti-aspirate not being a very a good kind of thing to take a sample and make our clinical decision that, you might have scenarios where your patient will not improve even on cholesterol on day second, third. So that is a time where we take a call and continue or go for vanco also. So that is something, I mean, how we mix and match with our diagnostic teams.
So yeah, I totally agree with you. There are cases and situations where we adopt that approach. And basically, if you remember, I said the person should be able to run the data in the mind. So when we have that kind of organisms growing in that unit, we would say, okay, go ahead, continue with the vanco, continue till we have final blood culture report as well. Drain cultures we really do not rely too much upon unless it is Enterococcus faecae. Then we would definitely, even if drain culture has to be taken with a pinch of salt, we can't put a fresh tube pigtail there, so we will consider that also. But by and large, this was to highlight that approach. So yeah, we would consider. Some places we would consider continue with vancomycin. Let's wait for the reports. We do see that.
One very last small point. I mean, there is always a great debate. Now the things are popping up with nebulization.
Yes.
So basically, in what doses you prescribe for VAPs to really be effective at the level of alveoli? Do you?
So for cholesterol, we ask them to give 3 million units every time. Usually it's 3 times a day.
Thank you very much.
Yeah.
So that is something we are exploring through our PQPD studies. We are simultaneously generating a lot of evidence with regards to cholesterol. There was a big question about it reaching the CSF, so we did it in pediatric population. We measured the CSF concentrations through different routes. This thing we are going to take up next. So this is simultaneously we keep working and generating these kind of reports. And cholesterol dosing is still a big issue. There is currently in acute and chronic liver failure patients we are trying to establish the dose. Some of the initial findings are kind of troubled us. So with that work we keep doing. The important point I wanted to make was if I can take it up, or unless there is a pressing question, audience first. And if we have time, please stop us if we can. If we have time, please stop us if we cannot. Please feel free to do so. Let it be the last.
Ma'am, I have a couple of questions. One is, how did you consider that it's a pathogen or it's a colonizer? Is it correlated clinically, or did you consult with the microbiologist whether the counts are high?
Yes, of course we will consult with the microbiology team, and from there only we have the confirmation that definitely it's a pathogen. I guess, ma'am.
Yeah, and there was mentioned, we consider now, over the last 2 years we started considering it as a possible contaminant also, considering this thing.
It is always
But colonizer. So we have the shemale chest X-ray new onset infiltrates, oxygen requirement was increasing, systemics is worsening in terms of inotropic requirement and increased counts. In fact, we use this clinical CPIS score also sometimes more than 6. In respiratory ICU, we are using that. In other ICUs, we are using it actually to correlate it clinically. So that consideration is always there.
Okay. The second question is, A. momeni was intermediately susceptible to cholesterol, whereas it was tested as susceptible to minocycline and tegacycline. So any reason of preferring minocycline over cholesterol?
So that was deliberately put there.
Yes. So actually we wanted to discuss about it because we see that this is the pattern of what report we get, that cholesterol is being intermediately sensitive.
So the CLSI breakpoint wise, they have removed cholesterol sensitivity of breakpoint from 2020 onwards. mentioning that colistin is ineffective for.
Let me take it, sorry to interrupt you, Dr. Apurva, you brought in the point that I wanted to discuss. Broad micro-dilution reports are what we are getting, and intermediate sensitive would imply we are not sure about the outcomes. We have found out the MICs from the previous, and most of our isolates were around 2. And what is important that most of our organisms, the outcomes are very consistently given in the right dose and route are responding. The outcomes are good. So it is the outcome what we understand from microbiology. It is the outcome which determines whether it can be intermediate sensitive or could be sensitive or resistant. So this information we have from our own data, that most of our isolates, which are labeled as IS, without one change in MICs that were being reported earlier, are responding. So we continue
and
with
don't you recommend international colistin?
She said nebulized colistin, and while not tigecycline, we have a black box.
Where the black box warning against dicyclic lines swap.
So we are rather reluctant. Another reason why not minocycline, we do make adoption. There is a big debate. The spectrum is wider, and we really do not want. We have discussed amongst us whether we go higher in the ladder or we choose a broader spectrum. So microbiologists have guided us on this, that I think it would be better to go higher up in such a situation.
In our setup, as far as A-bomb treatment is concerned, minocycline comes earlier to colistin. Colistin used to be the last resort first.
And this is the way we have worked.
And do you recommend monotherapy of colistin? Or
yes, so I think I can go on endlessly about that. So for sometime there was this transition from monotherapy to combination therapy, especially empiric this thing, and then we collected enough information to say that it is monotherapy given appropriately is working very fine. And combination therapy, in fact, 2 RCTs have shown with very similar kind of organisms that were evaluated, the kinds that we get, that there is no additional clinical benefit. So that was the turning point that we reported. 2 ICUs are still considering with that practice, and it is a case in discussion.
It is a case of discussion for ages.
Yes,
actually,
we give monotherapy.
there are a mixed group of opinions among the clinicians also.
Yeah, so RCTs have shown that there is no additional benefit, and in fact, if everyone agrees, we can actually generate.
Dr. Sagar, what is your recommendation?
Minocycline is bacteriostatic.
Sir, we
Trying to go minocycline or colistin.
so bacteriostatic, I think, please stop me, please feel free to stop me. Bacteriostatic in cider is more of a microbiological definition and with limited clinical implication. There is the way it is defined in the lab, and now it is being shown that even for serious infections like infective endocarditis, a lot of bacteriostatic agents are being used. So we are not guided by this classification for static or cider. Our decisions are more to do with possibility of misuse. It is available already also, so we don't want to get into the systems, and secondly, broad spectrum, because the resistance potential, I believe, would be better, more with the broader spectrum agent. Correct me if I'm wrong on that aspect. So those were the decisions that we, and there were enzymes.
I agree with ma'am, because static aside is an in vitro term, not an in vivo. Because even a cycle in vitro will be starting with a biofilm or any kind of instrumentation. So that's a very, very variable term.
Where each R counts. So should I go with minocycline? Why not?
If a colistin is contraindicated, sometimes we do consider minocycline as an option. We do. And especially had it been, say, infection in the, say, pancreatic necrosum, then we say go ahead and use tigecycline, minocycline, because the penetration issues will be taken care of. And possibly there is other organisms that are also working in there. So, but by and large,
this debate will never
No, we can end that debate. We can do that study and we can end the debate.
One small question, that your microbiology team did not report any of the sulbactam based combinations like ampicillbactam or sulbactam for Acinetobacter baumannii.
So I'll tell you, they do report, we didn't present it all over here, they do report that. But I'll also tell you, Cephalosporin is how they report and Ampicillbactam is what they report. Ampicillbactam we are not finding any susceptibility. Cephalosporin we are finding occasional susceptibility, but when we start that, we are very watchful because the outcomes have not been all that good, because we keep an eye on the outcome. We have, so what we say, we okay, de-escalate to Cephalosporin. That is the practice where the team is very good. Say for example, neonatology we do it pretty frequently because their team is very motivated team. And then they kind of, we also put in there, be watchful. So after 2 days, it will be reviewed. If there is lack of clinical response, then we take it on.
Kind of, we also put in there, be watchful. So after 2 days, it will be reviewed. If there is lack of clinical response, then we take a call.
Any experience with sulbactam as a separate drug along with maybe meropenem for Acinetobacter?
So I'll tell you, sulbactam alone, we had used say, around 5-6 years ago, we were using it as one of the options, and the clinical outcomes were not really very good. And it's 6 gram, a very heavy dosing has to be carried out.
Actually, we are already running late and we have a panel discussion. No. What I meant to say, we have planned a lot for panel discussion. I thought this could have evolved into the panel discussion, and because we have various points to raise. But we already planned it in other way around. So this can be the food for thought for next ASPicon. We are running out of time.
Thank you so much.
Thank you, ma'am.
Thank you so much, ma'am. Now I would like to invite Dr. Bhaskar sir to presenting the memento for the speakers.
Now I will request all the participants of award poster category to display their posters in the foyer outside the exit to your left. Please do it immediately. Next, we are going to announce the winners of the elimination round of quiz competition, which we held in the early morning. And the teams will appear on the stage for the final round of the quiz. The teams are as follows. 6th rank was secured by PGIM Chandigarh. 5th rank by AIMS Patna. 3rd and 4th, there was a tie between IMS BHU and JIPMER Pondicherry. 2nd rank secured by AIMS Delhi, and 1st rank was secured by AIMS Jodhpur. Congratulations to all of the teams. Stage round will take place after lunch from 2 p.m. to 3 p.m. in the auditorium itself. Kindly assemble well before. For now, I request our audience to break for tea. We will begin our next session in 10 minutes. Thank you.
Our next speaker is Dr. Sumit Rai. He is presently Additional Professor, Department of Clinical Microbiology and Infectious Diseases in Postgraduate Institute of Child Health, Noida. He has 18 years of experience in clinical microbiology, 42 research publications and 1 book chapter. He is MD Gold Medalist and has done postdoctoral certificate course in infectious diseases. He has won several awards like National Awards for Best Papers in Bacteriology, IAMM Delhi Chapter Awards for Best Papers in AMR and AST. He is the lead and technical assessor with NABL for microbiology and molecular diagnostics. Sir is a CLSI Premium member and editorial board member of Indian Journal of Medical Microbiology and has special interest in AMR, AST, WHO-NET, antimicrobial stewardship, infectious diseases. So I would request Sir to come on stage and share his wisdom on antibiotic dose adjustment in infections, the pharmacokinetics, pharmacodynamics and minimum inhibitory concentration of antimicrobial agents.
Thank you so much for the kind words of introduction. Before I start, just want to quote a phrase in Sanskrit, Vasudeva Kutumbakam. You must have heard about that the entire universe is one family, right? So we are made up of 30 trillion cells. The human body is made up of 30 trillion human cells. At the same time, we are inhabited by 300 trillion bacteria. So we are the world to those bacteria, right? So we actually behave more like bacteria rather than humans, because the way bacteria do plasmid transfers, we can transfer knowledge to each other, the kind of company we keep with each other. We are able to imbibe good things, like I've learned so many things from Dr. Purva, my mentors, Dr. Vikas Manchanda, Nusrat ma'am is here, Dr. Sarita is here, Dr. Vinod, and so many people I cannot name because of the paucity of time. But we do behave like bacteria. And the way that, we have been taught microbiology in our undergraduate times, and when we start our MD program, it's like, entering into a lag phase of the bacterial growth curve. Kuch pata nahi hota what to do, what not to do. Same goes with other branches also. Then you start learning, you start imbibing things, you go into your second year, third year, you read, study, disseminate knowledge, share knowledge. And at one time you have learned most of the things in a third year, you pass your MD exam, then if you keep on staying at the same place, you don't get to learn anything new, you go to a stage of stagnation and stage of decline. Then there is new food for thought. You enter into a new institute, learn something new, right? So that's how they behave. And this particular session on antibiotic dose adjustments, I've already apologized in case I make any mistakes. We've got very senior pharmacologists sitting over here, and I don't know why Dr. Vinod has put my name in this session. Maybe he's... So anyway, about the antibiotic dose adjustments, this camera is going to have some trouble because I keep on moving. I don't stay static at one place. So like bacteria, I'm like E. coli, I keep on moving. Anyway, okay. So basically, most of the things about the diagnostic stewardship has already been covered very nicely by Dr. Purva and Dr. Panda, Dr. Sagar. I'll be just discussing the basic insights about the integrated stewardship. It's a very wonderful concept, but the only issue is that we have to take the entire hospital together. Like I said, the entire universe is one family. So as a family, you have to take pharmacology, medicine, surgery, microbiology, all the departments together. And this is the ideal platform. The ASPCon is a perfect platform to showcase that particular integrity of all the departments. So you have been talking about stewardship. Yesterday, I think Dr. Arvind had given the definition of a steward. What is a steward? And I'll say, what is a waiter? So far, microbiology department was behaving like a waiter, right? So what is the AST report? Okay, susceptible to this, resistant to this, just like, he's ranting a menu of your, of a dhaba or something like that. But what a steward does is they'll ask you what you would like to have. You want to have Thai, you want to have Chinese, you want to have Japanese, you want to have Lebanese food. What suits your gut flora? I mean, what suits your palate? What suits your, habits, whether you want to eat vegetarian or non-vegetarian. So they customize your diet for you, right? So this is a classical brainstorm microbiologist. He just reads out a dietary of services. This is what I'll do for you. Finished, not beyond that. My time stops at 4 o'clock in the evening. And the the steward will customize your entire treatment for you. So the entire, the domain of the clinical microbiologist has really widened. It's really widened. It's not till the lab, and Dr. Purva is a live example as to how you have to need to extend it and integrate all the departments as much as possible. So as said that there are 3 pillars, as according to me, there are 4 pillars of integrated antimicrobial stewardship. The diagnostic pillar, the infection control pillar, the antimicrobial stewardship, and the community stewardship. And all departments are involved in some other way in different domains. Pharmacology is now involved in antimicrobial stewardship and the community stewardship. Dr. Sagar, he's involved in the entire community and taken it to the periphery in all these places. But now the microbiologists need to really gear up. We really need to gear up. It is not a back-end department. It is a clinical department. It's a clinical branch. Please, the first year PGs that come to your department, please prime them that this is not a 9-to-5 job. You can be called up anytime. You can be straightened up anytime. You have to be like, in fact, just 3-4 days ago, one of my technicians, he introduced me that Sumit sir to kabhi bhi raat ko aa jate hain report nahi karne ke liye. Sumit sir to kabhi subah bhi aa jayenge, Sunday ko bhi aa jayenge report nahi karne. So Dr. Purva, I've learned from him that these kind of active and proactive antimicrobial diagnostic stewardship is extremely important for patient care. So my hospital, we don't have a pharmacology department. And 2014-15, I got introduced with Dr. Ashish over here. We were together in Safdarjung Hospital. And somehow something instigated me to ask things about what is PKPD, let's discuss what are simulation softwares and all those things. So I had taken a lot of inputs and feedback from him. We've been friends since then, and we discuss also things. So many doubts, I keep on pestering him, please send me articles and all those things. So the domain of the microbiologist has expanded really, like especially with the, like just Dr. Sagar was saying just 10 minutes ago that because of COVID, the person whom do we contact as the microbiologist. So molecular diagnostics. Even as a technical assessor and a lead assessor, I can say that until you don't maintain quality control, again, we were sharing recently we were sharing some data on the WINSAR network, that's a WHO Indian National Surveillance Network. We were sharing data and we realized the data from many of the labs was so horrible. The quality control was so poorly maintained. There were people were reporting VRSS strains, people are reporting 50% prevalence of ceftriaxone-resistant Salmonella typhi, people reporting cephalosporins and enterococcus. So that kind of quality control is still lacking in the microbiology lab itself. So that is, we need it really pulled up. So these are you can see the job descriptions of all the 3 pillars: the antimicrobial steward, the diagnostic steward, and the hospital infection control steward. The community steward I'm not discussing, is probably out of the domain right now. So as you know that the drug risk, this is a signature slide. This, the drug resistance is really at its peak right now. Our baseline bugs are ESBLs and AMC beta lactamases. Our baseline bugs are not ceftriaxone susceptible, except for maybe Salmonella typhi. But more our baseline is AMC and 85% ESBLs and combination of AMC beta lactamases. So this is really a major issue for us, and therefore we need to ask ourselves this question: that are we giving the antibiotics in the right way, right? Are we not giving the wrong drug or the wrong bug, the wrong duration, just like Dr. Ashish had wonderfully cited in the slide? Are we treating contaminants? We just have a discussion about Acinetobacter and about the dosing and the frequency also. So all these, we never consider how the drug behaves inside the body. So to understand how the drug behaves inside the body, be the drug. Just imagine that you are a molecule of, let's say, piperacillin tazobactam, and you are put inside an IV line. And how will you come across? You go inside the bloodstream. How you encounter the RBCs, the WBCs, the proteins, the albumin, the globulin, the platelets. So many things are there inside the blood. So how much of blood, how much of antibiotics, protein bound, how much is albumin bound, what is the creatinine clearance? All these issues we often overlook whenever we are giving the treatment, because the clinician will go on the round. Most of the people who are not aware, this is antibiotic, give it stat, finished. How to give, what is the antibiotic posology कितना एंटीबायोटिक कितने सॉल्यूशन में कितना मिक्स करना है, टोटल वॉल्यूम कितनी बनानी है, कितनी देर में इन्फ्यूज करना है, this is not being discussed. So all these factors have to be taken in mind when you are, considering about the use of antimicrobials. This is a clinical case for the residents because it's better to have an interactive session. That this is a classical case of juvenile diabetic mellitus patient with complaint of flank pain, tenderness, and fever, and urine showing numerous pus cells. And it's got Proteus vivae, so Proteus mirabilis. There are numerous pus cells and an uncentrifuged urine. So we have specified it's an uncentrifuged urine, and it is resistant to the carbapenems and aminoglycoside, third generation sphalosporins and fluoroquinolones, and intermediate susceptible to piperacillin, tazobactam, cifobromsalvatum. I prefer to use the word susceptible rather than sensitive because the bugs don't have feelings for the drugs. They're not sensitive to it. They're susceptible, right? So it's susceptible, and it is susceptible to none. So for the clinical decision-making process, you will consider repeating the AST with imipenem, nitrofuran, colistin, and tirecycline, or consider a parallel blood culture, or start piperacillin, tazobactam, cifobromsalvatum in standard 30-minute bolus doses, or call the lab to find out the MIC values of piptazo and cifobromsalvatum, start nitrofurantoin as a standard treatment for UTI or none of the above. So considering this to be a case of a upper UTI, so we'll always call up to find out the MIC values in this case, because this is a you can call this a true infection because there are numerous pus cells are there are occasional casts, and the history says suggestive of an upper UTI. So in case, even if this not had been Proteus mirabilis, even then you should not have given nitrofurantoin. So you must have the clinical symptoms ready with you. What to be given and what not to be given is extremely crucial in such cases. And if this had been a case of a suprapubic pain with burning micturition, in that case also, you can't give nitrofurantoin, and this, because this is Proteus mirabilis. Proteus is intrinsically resistant to nitrofurantoin, colistin, and tirecycline. In any case, you don't give tirecycline in urine. So these things are unfortunately still not known to the microbiologists themselves, let alone the clinical side. So in this case scenario, you should always go in for something like a piperacillin, tazobactam, or a cifobromsalvatum in an extended infusion. And we found in one of the publications that the carbapenem resistant Proteus, which are, you can't give any colistin in that case, will respond to piptazo if given in a slow infusion. Why? We'll just discuss about that. So there are a lot of in vitro in vivo paradoxes. The IDSA guidelines in 2020 for treatment of MDROs, and even the 21 guideline MDROs, every stage they mention that if the patient is responding to a drug which is given as resistant in the AST report, continue that drug, don't change it. Don't change it, because the in vitro in vivo paradox is always present. There might be susceptibility in vitro, but resistance in vivo, and vice versa also. And there's the reason cited why, because like Dr. Purva had cited yesterday, the 90-60 rule. 90% times the susceptible antibiotic will respond, the bug will respond, and 60% cases, the resistant will also respond if given judiciously. So we know that the triad is not actually a triad of the infectious disease, it's actually a presence of the commensal / colonizer also, because if you start attempting ampicillin for maybe a sore throat, that will get neutralized by the moraxella, which is producing the beta-lactamase in the throat. So those kind of things you must know, that the drug has to pass through the host and then reach the true pathogen. And in the meanwhile, it has to encounter the commensal or the colonizer also. So it is a pretty complicated process, not so simple as we normally would think it might be. We have to take care of things like the age and the sex of the patient, the body composition, the physiological condition of the patient, pregnant, obese, what are the food patterns, alcohol consumption, tobacco consumption, things like, what are the medical insurances, whether the patient can afford the antibiotic or not, and the dose and the frequency and all these things. So multiple things have to be considered before you're finalizing the report. So it is a fact that one size does not fit all. You have to tailor make the report, especially in those cases where the usual physiology has been altered, especially those cases, overweight patient, pregnancy, diuresis, patient on renal replacement therapy. All these are different indications where you have to tailor make the therapy, and how you do that by the pharmacokinetic and pharmacodynamics. So the dynamics of clinical decision making is extremely complicated. I can understand how difficult is it for the clinicians when they don't have much clue about, when much inputs from the microbiology department, much input from the pharmacology department. It's very difficult for them to judiciously use the antibiotic, and how to give the antibiotic, the PKPD, in complex situations when the cultures are coming positive and the patient is not responding on the usual doses. So it's very difficult for the clinicians to go about that. So we need to all work together as one family, as a one integrated antimicrobial stewardship has to be taken care of. So like this concept is very, very good. Dr. Panda has already mentioned about the integrated antimicrobial stewardship, and we all need to introspect and ask ourselves such questions, that whether I am giving the right antibiotic, whether the patient needs the antibiotic, what are the different drugs that I can give. So all these things you must think about before you start or contemplate about giving the antibiotic. So there are numerous dynamics which are involved in clinical decision making. So these 4 questions can always help you. The 4 moments of antibiotic decision making can help you. Does my patient have an infection, or is it a colonization, or it is a commensal flora? Have I ordered the appropriate cultures? In my lab, we have banned the use of any kind of swabs. No swabs from pus samples, no endotracheal tips, no urinary catheter tips. Please send us only aspirates, or if possible, if you need to send only a pus sample by swab, please clean, debride the area totally, completely with saline, and then express the fluid, whatever fluid that you're getting. Try and send me at least 0.5 ml. I'll still manage with that. So all these, the ideal cultures should be taken care of, and when to stop the antibiotics, when to de-escalate, when to escalate the antibiotics, and the duration. All these are the questions that you need to ask yourself. And these are the 2 places where the PKVD start mattering. And these are also the golden rules for antimicrobial prescribing, the mind me rules, that your therapy has to be microbiology guided, ideally. Indications should be evidence-based, and ideally you should use a narrow spectrum and a focused target on the bug to be taken care of, and minimize the duration of therapy and ensure monotherapy in most of the cases. If it is focused, you can focus therapy ideally. So pharmacokinetics is what the body is doing to the drug, and the pharmacodynamics is what the drug doing to the bug in this case. So you have to be very careful about the underdosing and the overdosing. If you are underdosing, then you are creating resistance in the bug. If you're overdosing, you're creating adverse drug reactions on the patients. So that kind of titration is very, very typical, and certain amount of therapeutic safety has to be seen for every antibiotic. So that therapeutic safety, that kind of inputs the pharmacology department can give us. So that's the normal simplified process of the standard drug dosing. If you developed a new drug for a particular bug, in that case you check for the wild strains, you check for the epidemiological MICs, then you see whether you see the therapeutic toxicity of the drug, then you determine the maximum safety of the dosing of the drug, and then you go in for clinical trials and you determine that this is the dose that I can safely give to the patient, and on this dose the bug would react at that particular MIC. So that's how you calculate your breakpoints also. So basically your MIC, or the minimum inhibitory concentration, it is the lowest concentration showing the no visible growth. So it is not a true value, because if you are detecting an MIC of, let's say, less than 16, but more than 8, but less than 16, it could be anywhere between 9 to 15. It could be anywhere from 9 to 15. So you don't really know the actual values, but then MIC is the only representation in the something wrong with the slide. It's showing over here. It's moving here. Okay. So audiovisual glitches are the pathognomonic of a successful conference, right? So that's it. So MIC is the phenotypic endpoint in a defined and a standardized but a highly relative system. So what we are detecting right now, like what we just discussed with Dr. Sagar also, we talk about static and sidal drugs. Those are actually in vitro definitions. In vivo, they may act differently, right? So it is always, there is a paradox present because we don't know what is it. So it's a highly relative system. The human body is highly relative. So it is a standard measure of the activity of the drug against the bug in vitro. So that's the best guess that we have got to take care of a particular infection. So it's a, like I said, it's a static model. And what we need to remember is that the unbound drug, which is not protein bound, that is a drug that actually diffuses in the extravascular sites, and that brings about the changes or the killing of the bacteria. And when I say that the entire physiology is altered or deranged, so we must know what is a normal physiology. So what is sometimes done is that all these different parameters like weight of the average weight of the patient, the average BMI, the average protein binding of the drug in a patient, in a healthy human being, average creatinine clearance, all these things, when they are taken into account and together they're put in a software, we can make Monte Carlo simulations as to how drugs would behave in vivo inside the body. So they can be incorporated as a mathematical statistical software for predicting drug dosing, and on basis of Monte Carlo simulations, you can have softwares like your colistin ICU, Coli ICU software is there, aminoglycoside dosing softwares are there. I don't know how accurate they are, but they are all existing on some scientific basis. So I'll just skip through. I've already told you about what are the epidemiological or the wild type MICs. These are MICs which may not have any clinical relevance, but we just want to find there's a bug which has got no mechanism of resistance. We find a new drug, we check for the MICs, that is the epidemiological MICs. Now we don't know whether that MIC will be clinically effective or not. Once we do studies and correlate with the clinical outcome, those MICs become the clinical MICs, and then these are the MICs which are mentioned in our CLSI M100 documents. Now what we are interested over here is the SDD, susceptible dose dependent, right? So SDD is basically a pharmacological MIC or the PKPD MICs, where we are actually able to calculate, okay, at this particular dose to the patient, at this particular dose and this particular MIC, the patient will respond. Now the problem with CLSI is that CLSI does not mention the duration during which the antibiotic needs to begin, whether it's to be given as 30 minutes or half an hour or 1 hour or 2 hours, 3 hours. That does not get mentioned by CLSI. This is just a outline as to what PKPD, we don't call it PDPK, right? We call it PKPD because PK is the first thing that is encountered by the bacteria. By the antibiotic. It undergoes adsorption, distribution, metabolism, elimination, protein binding, and then it achieves a certain concentration in the serum, and then it reaches the actual site of the infection where the actual MIC matters and it exerts the biological effect. So it is these are the parameters that we need to take care of in the pharmacokinetics, the absorption, what is the oral bioavailability, what is the drug interactions, distribution in the body, the lipid solubility, the blood flow, hydrophobicity and the hydrophilicity of the antibiotic, the metabolism, and of course the excretion. So once we give an antibiotic to a patient, this is a classical typical concentration time curve. Let's say you give the antibiotic at 0.0 over here. Let's say it's IV and it starts rising at a particular concentration, reaches a maximum concentration on the Cmax, and it slowly falls. This is after a single dose. So this is the maximum concentration that it reached. This is the MIC of the bug. So approximately from this time to this time, because the time was mentioned on the x-axis, from this time to this time, it is above the MIC. So on the basis of how the pharmacokinetics of the particular antibiotic is, those antibiotics get classified into 3 kinds. So the first kind is the concentration dependent antibiotics. This was just mentioned yesterday in one of the slides. In this case, what happens is the total concentration, maximum concentration reached in the blood, that is what matters. The amount of time it remains in the blood is not that much valuable. It is the amount total concentration reached in the blood. So that is typically exemplified by the aminoglycosides and the quinolones. Then the other extreme is those antibiotics which are effective only when there is a particular duration of exposure to the bug. It doesn't matter how high it is of the MICs, even though convention says that it should be above 4 times the MIC, convention says, but then even after that, you have to see that it remains above the particular MIC for a particular time, and the greater the time of exposure, greater is the killing by that particular antibiotic. It's typically exemplified by the beta-lactam group of drugs. And then the third kind, which have the property of both, they are the time dependent with moderate to persistent post-antibiotic effect. Why this happens is because, and of course, we need to keep in mind that the MIC remains the constant denominator in this case. The higher the MICs, the lesser effective the drug is in all the cases, because higher the MIC goes, the Cmax to MIC difference also decreases. This particular time also decreases. So higher the MICs, lower are the chances of the bug getting destroyed by the particular antibiotic. Now, if you see this curve very carefully, because we need to understand that, like I said, to be the antibiotic for a change, just try to understand if this, now this case, you see all the cases, the dose is the same. This 500 milligrams dose is constant. There's no change in the dose, but the way that it has been given is different. The red line shows this 500 milligram orally. So you see 500 milligram given at time 0. So slowly the concentration rises in the serum and reaches somewhere around 14 milligram per liters, somewhere over here. So, and it slowly falls. So despite giving 500 milligram, so the oral bioavailability is not that great. Otherwise, you see it is a 1 hour infusion, that's parenteral dosing. Parenteral dosing has got 100% bioavailability, right? So compared to the 100%, this is somewhere around 50%, 60% only. This one is, this triangle is IV given over 1 hour infusion. So it rapidly rises and falls rapidly. The third one is your 4 hour infusion in the green line. So it slowly rises and falls slowly. And the last one is a continuous infusion. So if you see that this is the kind of thing that we need for the concentration dependent antibiotics. This is the kind of thing that we need for the time dependent antibiotics. This is another nice example. The time kill curves for Pseudomonas aeruginosa control strain 27853 exposed to the 3 antibiotics: aminoglycoside, fluoroquinolone, and a beta-lactam drug. Now this black line is the control. Control means there is no antibiotic here. So this is the this is the amount of the bacteria. These log curves shows the greater growth or the increased turbidity in the liquid medium. This is the time. So as and when you see time goes on, this is without the antibiotic, this keeps on rising. So it's normal. It will rise. Naturally, there's no antibiotic, so the growth will be there. If you add a concentration of 1/4 the MIC of the bug, right? 1/4 the MIC, what will happen is there'll be some amount of decrease in the or a shortening of the growth, but then ultimately it will also rise. But what happens if you use the red line that equivalent to the MIC? That is, there's a steady fall in these 2 antibiotics over here also. What I'm trying to say is that even if you increase to 4 times the MIC, 16 times the MIC, 64 times the MICs, all these lines, they are together. They're close apart. They're close together. So there's no difference if you increase the concentration in this case. So this is a beta-lactam drug. You keep on increasing concentration, won't matter. But if you increase the duration of exposure, it will matter. Similarly, these are concentration dependent antibiotics. As you can see, keep on increasing the MIC, the growth falls further. So in this case, what happens is these are concentration dependent. So in this case, the concentration achieved in the blood, that is more important. In this case, the exposure time is more important. So this is just a simple table just to tell you that what are the concentration and the time dependent antibiotics. Concentration dependent antibiotics usually have got a good post antibiotic effect. The time dependent have got a poor post antibiotic effect. And the third one, they have got intermediate, like time dependent with a good post antibiotic effect. So the reason for the post antibiotic effect is probably because the drug gets bound to the protein and slowly it gets eluted from the protein slowly, and therefore it is able to exert a constant sidal effect or a static effect. And the damage that it normally creates a permanent damage to the machinery, like say, especially like you see the DNA gyrase being damaged by the fluoroquinolones, and the 30 and the 50S ribosomal proteins being damaged by the aminoglycosides. So post-antibiotic effect is primarily a property of usually the concentration-dependent antibiotics, and Except for carbapenems in Pseudomonas aeruginosa, beta-lactams don't have any post-antibiotic effect. So there's some basic fundamentals that we need to remember is that altering the dose primarily affects the dose. That's dose, that means 500 milligrams to 1 gram. Primarily affects the Cmax to MIC ratio. Cmax to MIC and the area under the curve to MIC ratio. So the defined parameters for these three types of antibiotics are the concentration dependent antibiotics. They are defined as Cmax to MIC. The time dependent are defined as the percentage of time the antibiotic is, the exposure is more than the MIC. And the third one is the total drug that is given divided by the MIC. The area under the curve represents the total amount of drug that is given under the is to the MIC. So for time dependent antibiotics, the rate of bacterial killing is maximized at low multiples of the MIC, and achieving higher concentrations do not result in increased killing. So please keep in mind that all concentration time dependent antibiotics, you have to give prolonged exposure or extended infusions wherever possible. And of course, you also need to know what are the hydrophilic and what are the hydrophobic antibiotics. The beta-lactam drugs, the glycopeptides, aminoglycosides, they are primarily hydrophilic and they are got primarily renal excretion. And the lipophilic ones, the macrolide tetracyclines, they primarily have got a hepatic metabolism and they have got better activity against the intracellular organisms. So hydrophilic or lipophilic, you need to know because that will tell you whether it will affect intracellular bacteria or not. I'll just skip this slide, we're running short of time. So what are the conditions when PKPD are clinically relevant? Like I said, whenever there's an altered physiology of the patient like obesity, there's renal insufficiency, neonates, they've got decreased clearance of aminoglycosides. Whenever we are reporting aminoglycosides for neonates in our institution, normally I keep the Nelson in front of me. And whenever we are recommending, let's say, gentamicin, so we write down the doses of gentamicin if it is a gestational age of 30 days, with a postnatal age of less than 14, more than 14 weeks. So those kind of things we take care of and try to implement it on our AST reports. So like I said, that the one size does not fit all. I'm rushing through these slides because I need to show you some good examples also. Like whenever there's a large fluid shift, there's a third space alteration, third space accumulation is there, there's less drug is available. Whenever there's organ dysfunction or there's increased cardiac output, there's increased use of vasopressors or inotrope use. Again, there is augmented renal clearances there. So again, the antibiotic gets rapidly cleared from the body. So again, you have to adjust the doses. If your albumin levels are decreased, there's less protein binding. Again, there's a lot of unbound drug. So there's there's a unnecessary increase in the antibiotic concentration in that cases. Of course, then there are extracorporeal interventions like ECMO or renal replacement therapy. All these interventions, they will decrease the concentration of the antibiotics, and therefore you need to alter the dose, duration, or the total exposure time. So this is a very wonderful reference you can follow. This is the British Society of Antimicrobial Chemotherapy ebook on AMSP. I think Dr. Pura will find a nice reference over here, because this will give you how to change the PKPD in altered conditions like pregnancy and obesity. Like what are the changes that need to be made for different antibiotics under different altered physiologies. So when you get let's say you get a aminoglycoside MIC, let's say it's 4 for amikacin, it is in the susceptible breakpoint MIC range. So what do we do? If the MIC is in the susceptible range, you just need to give a single dose OD. If it is, let's say, in the intermediate range, let's say it is 16 or maybe around 32, in the intermediate range, you need to give a single high dose OD. And if it is in the resistant range and you still need to give the antibiotic, you can convert that into an AUC MIC kind of a farm PKPD thing, like what we can do for cystic fibrosis, which is, again, I can give you an example later on. So these are the indices that we need to measure, need to keep in mind, that for the carbapenems, 40% of the dosing time, let's say the dosing time is 8 hours. So 40% of the 8 hours, the MIC, the concentration needs to be above the MIC. So that's why the crux is that you need to increase the exposure time in case of all your time dependent antibiotics, and give a OD dose for the concentration dependent antibiotics, because dividing a total dose of the aminoglycosides into multiple parts and giving it as a BD dose of no use, rather than the total dose has to be combined, clubbed together as a single dose and given OD only, because the Cmax is the most important. So, like I mentioned, this is a case of cystic fibrosis. It is susceptible to the carbapenems, and it is SDD to cefepime. And for treatment in this case, you will choose Miro high dose and Genta high dose. So they're the same two drugs. It can be given in so many different combinations. Miro usual dose with Genta in high dose, both in 30 minutes bolus dose. Usual dose of Miro over 3 hours and Genta BD over 30 minutes, or usual dose of Miro over 3 hours and Genta BD over 3 hours. So you would normally think that, Miro 3 hours is fine, but Genta we can give in 30 minutes. No, but in this case, what happens is, like I said, in cystic fibrosis cases, what happens is the aminoglycosides, they follow the AUC MIC kind of a curve. So in this case, you need to be careful that in this case, you have to give aminoglycosides a little more frequently than OD dose. You probably can give it as a BD dose or maybe TDS. Otherwise, normally they have to be given as OD only. So in this case, they follow the AUC to MIC ratio. So there are issues, like I said, there are issues with the aminoglycosides in neonates because they've got a decreased clearance of the aminoglycoside because of they've got a poor renal function. So that's why we follow this particular table from Nelson. Whenever we are recommending aminoglycosides for neonates, we especially get a lot of OXA48 kind of carbapenemases from our neonatal ICU. They are usually only amikacin susceptible or maybe even cotrimoxyl susceptible. So we try to avoid in neonates. So maybe if the renal function is fine, we can go in for that. And so accordingly, we give the dosing based on the gestational age and the postnatal age of the neonate. This is another case of what we call as the front loading regimens, or what we call as the loading dose. What is the basis of the loading dose? Again, a case of chronic IDDM with hypertension, with congestive heart failure in the ICU, with sepsis, with Klebsiella pneumonia. So this is a sick patient. This patient is really sick, right? He is elderly patient with a chronic disease, with hypertension, with congestive heart failure, with sepsis. So this is a sick patient. So what do we do in this case? We don't want to waste any more time. We want to give some kind of a front loading regimen. So I have just acronymed as FLR. So what we do is this case, the meropenem is in the susceptible breakpoint MIC. That's absolutely all right. Genta is also in the susceptible breakpoint MIC. So we don't need to increase the dose. We just need to divide our total meropenem dose for the day and give around 25% of it to in the front loading regimen. What is the basis of that is, like if you see, this is intermittent infusion, rapidly given, rapidly falls, rapidly given, rapidly falls. This is extended infusion, slowly given, falls slowly. Again, the exposure time is, now in this case, what is happening in this case is there's a extended or continuous infusion in this case, the third line. What happens in the front loading regimen is that we are missing out on a certain time period, like this one. We are missing out on the initial part over here. Now, if I give a beta-lactam drug as continuous infusion, it will start rising here slowly at probably around 6th or 7th hour. It will reach at the value above the MIC. So that is the part where it will be effective. So we're losing out on 7 hours over here in this patient. So what we need to do is, if you see, the blue line is 3 gram IV, 24-hour infusion. The red line is 1 gram IV as a 1 hour infusion, followed by 2 gram in the rest 23 hours. So the total dose is same. The total dose is 3 grams for the day. Entire dosing same. We not increase the dose, but we just divided it is like that we are able to cover for this initial 7 hours in the front loading regimens, right? So whenever you have a sick patient, high inoculum patients, serious patients, sepsis, so always we can go in for a front loading regimens. So we can cover this initial 6 hours of gap and save the patient early as possible, because every hour counts, right? Every hour we are delaying, the mortality increase by 6 to 7%. So we need to know that what should be the elimination route also, whether it is hepatic or biliary, whether it is so broadly you can see that most of the antifungals, they are hepatobiliary excretion is there. Most of the beta-lactam drugs, they are got a renal clearance. Most of the antivirals have got renal clearance. The ATT drugs have got a hepatobiliary clearance. So if you can see that, you can judge whether patients kidney function tests and liver function tests are within normal. So accordingly you can change the antibiotic accordingly. And of course, you also need to know the bioavailability of the antibiotic, which is got excellent. You can shift from IV to oral, because IV to oral is also another low-hanging fruit that you can always, harness and improve upon your AMSC practices. This is another example of, let's say, this is a 35-year-old woman with burns patient, and the blood, she's developed fever on the 4th day of admission. The blood culture isolates Pseudomonas aeruginosa susceptible to any of the uridopenicillins, like the anti-pseudomonal penicillins. So which regimen provides the highest percentage? So which of these treatment regimens will provide the maximum exposure of the anti-pseudomonal penicillin to this particular drug? Now, this is an example I took from one of the softwares. I'm sure that ma'am would be able to enlighten us better on that. So it's again 4 gram infused over half an hour, 3 times a day, total dose 12 grams. 4 grams infused over 4 hours, 3 times a day, total dose 12 grams. 8 grams, half an hour, total dose 24 grams. 4 grams, half an hour, 4 times a day, 16 grams. 8 grams infused over 24 hours once daily as a sustained infusion. Total dose is 8 grams. So once you, like I said, there are numerous softwares that are available. I'm not aware about. I've just briefly gone through these softwares. Again, like ma'am can tell us better. So once you enter these things on these different parameters on the software, you'll find that you don't need a high dose of the antibiotic in this case. You can manage with a very low, 1/3 the amount of the antibiotic, and you can give it as a continuous infusion and still able to achieve the maximum exposure time, like you can see in this particular software. This is the TDMX software for piperacillin, and this is what is the targeted achievement. You want what percentage of time you want piperacillin to be above the MIC. You want 50%, 60%, 70%, 80%. So they've kept it as 80% over here. And then you want to give it as a BD or a TDS or a QID. So there are 3 QID dosings: 4 gram half an hour TID, 4 gram 4 hourly TID, 8 grams half an hour TID. And there was one QID scenario, and there was one sustained infusion scenario. So once they entered all these parameters on the software and calculated, they found this one, the last one, that is 8 gram over 24 hours given as a continuous infusion will give you the maximum exposure of piperacillin to the bug, and therefore this will produce a maximum killing of the particular bug. So this is where the cost cutting will also come. You don't need to give 24 grams, 3 times the total dose. You need to give it slowly and try to do a continuous infusion whenever you're encountering such cases. So this is what we call as a Hartford nomograms. What happens is that this is a total dose given over the entire day, and this is how it is given. And it is found with this particular, even if you give, let's say the purple line. Purple line is just 1.5 gram daily, 3-hour infusion given three times a day, 0.5 grams. This is able to achieve the maximum amount of the probability of target attainment. Probability of target attainment is that what percentage, what are the likelihood that you are going to achieve this particular concentration, and this will be able to kill the bacteria. So that is a probability of target attainment. So this is 100% target attainment. So even if you keep 3 grams, 1 gram 3 times a day as a 3-hour infusion, you'll see even with the higher MICs, you can achieve on almost 100% probability of target attainment. So, and what you can have this PTA, probability of target attainment, can be the greater the exposure time, the greater is the killing. So that is the main crux of the story. So there are smartphone apps which are available, like the Colli ICU app. You can use the aminoglycoside doser apps can be used for calculating these doses and how you can give them. This is just an example in the Appendix E for those who are in the microbiology lab. This is CLSI Appendix E, which tells you what is an SDD, or a susceptible dose dependent. That if the MIC is 4, then can be given as, normally it is, if the MIC of cefepime in enterobacteries is 2, so you give normally as 1 gram administered every 12 hourly. But if the MIC is higher, 4, so you have increased the frequency of the antibiotic, like 1 gram, same 1 gram here. Instead of 12 hourly, you give 8 hourly. So that's 3 gram over in the entire day. Or you can give us 2 gram given 12 hourly, that's 4 grams. But CLSI does not mention that it has to be given as an extended infusion, right? Maybe that's for us and the medicine and pharmacology people to understand the fact that this has to be given as extended infusions only. So now I'll come to something that already has been explained by Dr. Purva, that many of the times we see that, plus, 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 1 plus, 2 plus, 3 plus on our AST reports. And the clinicians ask us that, you give me 24 antibiotics, which is the best one to give. So what we has already been told yesterday is about the therapeutic index, or this is the most practical index that we are using. Dr. Purva has been using us on a software. What I'm trying to tell you that this can be used manually also. You don't need to have a software to calculate the therapeutic index. You can do it manually also. Before I go on to that, I just want to tell that how we are able to implement some basics of the AMSC practices. It's like we're doing only selective reporting for Salmonella typhi. We're doing only selective reporting. We are reporting only azithromycin, P-flox, nalidic acid, cotrimoxazole, chloramphenicol, AMPI, and Cipro. We're not reporting any third generation failure. So we are doing a selective reporting for all our Salmonella typhi isolates. And in fact, I got a letter around one year ago. I got a letter from the MS, who happens to be the HOD of pediatric medicine, and he said that you're not reporting third generation Sphaerosporus. Please give me an explanation. So I returned back with a 3-page type letter that with all the evidences that this is not to be given, this is how we will report it, this is as per guidelines. And after 1 year, just during the World Antibiotic Awareness Week, when we are presenting our antibiogram, he corroborated and supported my finding that yes, all our Salmonella typhi patients confirmed they are all responding on ampicillin, and ampicillin is working better than ceftriaxone. I told him that the therapeutic index of ampicillin is much better than ceftriaxone. Please shift to ampicillin, not ceftriaxone. Please spare that, because we've already isolated 3 cases of confirmed ESBL producing Salmonella typhi from our institute. There have been cases from AIMS also. There have been cases from other places also. Ceftriaxone resistant Salmonella typhi is another threat where you will require immunopenem to treat plain simple enteric fever. Right, so we don't report any third generation cephalosporins, and we are putting up all our quality controls on a daily basis. We have not shifted to any other weekly QCs also. We are putting up daily QCs. So this is the backside of the report. Like Dr. Pura has got a 7-page report. We just have a 2-page report because our pediatricians don't have enough patients to see these reports. So if you can see all, I don't think you can see it, but all these things are hidden. All the carbapenem selective reporting, you see it's all the selective reporting. Only ampicillin and cotrimoxazole is reported here. And ampicillin, the therapeutic index is 8/2, that is 4. It works better than ceftriaxone. So we also said that azithromycin resistance is also rising in our institute. Earlier we had around 85% resistance last year. It's now almost gone. Sorry, we had around only 85% susceptibility last year. Now we are down to 75% susceptibility for azithromycin. So please use azithromycin very carefully. We have an orthopedician in this August gathering. I'll just discuss one case with him also. If you can, focus this in more clearly. This was a case of a chronic prosthetic joint infection, and my friend from Chandigarh, he called me up. He said, "Tell me what to do." This is a 80-year-old man with aortic stenosis. We've operated him. He's got a chronic prosthetic joint infection, and we can't reoperate him. We can't take out the prosthesis because it's a high-risk surgery. So what do we do? So he sent me the Vitek report. I gave him the therapeutic index-based report. I don't know how well it's going to work in joint infections compared to bloodstream infections, but it seemed in this case that piperacillin tazobactam along with gentamicin would work better. And I told him that please give this thing. So he said, no, nothing doing. Tell me how to give the drug. Dawai kaise deni hai mujhe batao. Tell me how to give the drug. So I told him that no, start this thing, give an antibiotic timeout, because this is normally you give an antibiotic timeout around 72 hours for bloodstream infections, but this being a joint infection, it will take time for the antibiotic to reach the site. So give it a time of 10 days, a week or so for the antibiotic to react. He said, no, let me know how to give the drug. So I made him an antibiotic posology. I told him that take piperacillin tazobactam 4.5 gram every 8 hourly. That's 13.5 gram daily. This is the extended infusion. You'll do it. Add so much of saline. The infusate must be delivered in not less than 3 hours, along with gentamicin. This is the dose per kg body weight. So I calculated the entire thing from him, and then he replied back that, okay, hi Sumit, it's 3 weeks post-op now. The serological markers have come down, almost normal. Stitches are dry and removed. Clinically, the knee is silent. Could give Genta for 9 days. So we discussed the entire case, and we came out that now we can wean off the patient from IV to oral. So we went back to the IDSA guidelines, we discussed the IDA guidelines, and fortunately this case was already susceptible to ciprofloxacin, so we shifted him to 750 milligram BD for a long term. So that's how we discuss, when it comes to AMSC practices and how to give the drug, how to, so prolonged infusion really helps, right? So what are the antibiotics? So I'll just skip through this slide. I'll give you another example. Okay, this part already has been discussed, but still I'll discuss two more cases as to how we went in for therapeutic index-based reporting. So we got an isolate of MRSA, and in this case we went in for vancomycin along with clindamycin. In this case, the vancomycin MIC was 1, and the breakpoint MIC was 2. For clindamycin, it was the therapeutic index was again 2. So we had a therapeutic index for vanco and clinda we gave it as a combination therapy in this case. We also isolated Pseudomonas aeruginosa from 2 neonates, 2 different cases again over here. Now the interesting part, the interesting part over here is that, okay, see, if you can see, this is piperacillin tazobactam and cephalosporin sulbactam were intermediate susceptible. This is piptazo intermediate, ticarclav intermediate, cephalosporin sulbactam intermediate. It was susceptible to imipenem also and even doripenem, all these, but then we still recommended that you please give, because still in the intermediate zone, we recommended still that you can give piperacillin tazobactam again as a extended infusion and still get a treatment. This patient was not shifted on carbapenems. The patient was given piperacillin tazobactam as extended infusion, and the patient got treated. So what I'm trying to say, don't need to go to carbapenems, don't need to go on very high-end antibiotics. You can still, even with the intermediate breakpoint MICs, if you get, still you can achieve treatment success. This was another case where it was susceptible to carbapenems, but we went in only for cefepime therapy. This is another case of selective reporting that we are following with the baseline note like Pseudomonas is intrinsically. So this part of the report, or the reports that you see in the upper part of the report, is WHONET generated. We are using a software called as WHONET that's freely available on the internet, and we have done multiple workshops also on that, and we are around 20-30 labs in Delhi. They're all using the WHONET software, and we are sharing our data of WHONET. WHONET will also we can enter our reports on the WHONET, take out a printout in real time. So we have entered the data and we have taken out the printout also. This is the part that WHONET gives you, this part. And this I have made templates on my own. So all these templates go with these footnotes that this is Pseudomonas, it's intrinsically resistant to all these antibiotics. So we give the footnote that what is the best suggestive antibiotic in this case. And of course, as the infection prevention control measures, we keep on reminding them about the 5 moments of hand hygiene. So the AMSC practices which I am following at PGI, now we call it PGICH. Last ASPicon, Dr. Sagar had kept a question for the students who will name the full name of Dr. Sumit's institute, the super specialty postgraduate institute, and all that. Now it's been shortened to Postgraduate Institute of Child Health. Dr. Sagar, it's very simple now. Okay, Postgraduate Institute of Child Health, PGICH. So it's in Noida. So what I do is we do only selective reporting, cascade reporting, like I've shown for Salmonella typhi. The lab is open 24/7. I am available on campus. My house is so close to my lab that my laptop catches the Wi-Fi from my home. It's so close by. So what I'm trying to say is that the proximity, the residential proximity also helps you improve on your AMSC practices. Dr. Apurva is also staying on campus. 7 o'clock he reaches his lab. So that's the kind of beauty that of the AMSP, that if you are so ingrained with your AMSP practices, with these kind of things like residential proximity, you can. So lab is, like I said, lab is open 24/7. My technician, all the technicians are staying on campus, so they can come anytime they want, whether it's a holiday, whatever it is. There's some misprint over here, I think. So unless it is a pus swab, it is a catheter tip, or it's a ET tip, we don't accept samples. We have a list of critical alerts that we are using it on a daily basis. We have tried to decrease the turnaround time by real-time reporting, by holiday reporting, chahe chutti ho, rain and sunshine, whatever it is. Even if it is raining, we can come from the basement also. So don't even need to use the umbrella also. So we are doing therapeutic index-based reporting, especially for blood cultures. All the reports, they are being tailor-made, and we immediately WhatsApp whatever the moment you get any kind of gram negatives in the blood culture, it flashes, we immediately call the neonatologist, or usually most of the samples are coming from neonatology or from pediatric hemato-oncology or from pediatric medicine. And of course, we have got a case following up being done in real time. We go back to the wards, we check on, like he said, that pathogen directed AMSP. We isolated all odd bugs, like, what do you call it? We have Stenotrophonas maltophilia, we go bedside, the patient is healthy, we don't report it, right? So all the reports are being entered in real time on WhoNet and the clinical footnotes, as you can see. And one practice that is being strictly now followed in pediatric hemato-oncology and neonatal ICU is the extended infusions of all beta-lactam antibiotics. So the take-home message from this side is that please, for the clinicians specifically, that please ask for the MIC values. It should be made mandatory for vancomycin, colistin, nettlemycin, and mupirocin especially. All antibiotics for category 3 and 4 patients who are in the IPD in the ICUs, and must be reported with an interpretive criteria, not just as the MIC value, as whether it's susceptible or resistant or intermediate. And all clinicians, please, they must administer beta-lactam drugs in more than 3 hours infusion and never as 30-minute bolus doses, unless it is a UTI infection. Only in UTI, you give lower UTI, you give it as a maybe rapid, but not as this thing. Upper UTI again goes back to 3 hours infusion as per the IDSA guidelines. So must include your cumulative antibiograms and present it as frequently as possible. Please study and implement the CLSI and UCAS guidelines. You must know what to diagnose and what not to diagnose. Reduce the antibiotic hang time. So hang time has got all different definitions. Like Dr. Sagar is taking around, let's say 9:30. He says that, okay, we start with tazobactam. It starts at 1:30. So that 4 hours gap is the hang time for this particular case. Say the drugs to be kept near the infusion pumps versus bolus dose. So you need to have a lot of infusion pumps in your institute. Follow the 5 modes of hand hygiene and routine regular interactions, and academics can. So for the administration, if we have any administrators here, please, automation is the key word over here. Automation helps you a lot in reducing turnaround time. Be liberal in spending on automation. Must not lose the wisdom of the conventional techniques as well, because I'm putting up Curvivore as well as the Vitek along. Both the things are going hand in hand. Microbiology lab is 24/7. There should not be any compromise on that under any circumstances. All the point of care tests, like AIMS Delhi has got, I think, blood culture system right next to the patients, right in the ward. We had seen. So there's the moment they take out blood culture, they don't need to wait that it has to go to the lab. They incubate it immediately in the bedside only. So that's a very interesting example we can follow from AIMS. Rapid diagnostics have to be included to rule out, viral infections, to stop antibiotics. We need things like BioFire. I mean, they are expensive, but we need things like BioFire. And trained manpower is required. Education is required, and a lot of infusion pumps for the extended infusion of beta-lactams antibiotics. So with that, I would like to end my talk. Any questions? So I've gone little rapid on this thing. In previous talks, people have confused me with a pharmacologist, but I've learned a lot from pharmacologist. Dr. Ashish is here. I've been interacting with him often on. Nusrat ma'am is here. So I've learned a lot. And the one good thing is that, my Dr. Pramod Sharma, he has in Bhopal, pediatric surgeon. We are staying together. So we used to go for the night. He used to go to the night rounds. We used to go to the lab for reporting. So that is the kind of camaraderie that we all need to develop among different departments to implement an AMSP. Like even we are discussing Dr. Purva, that there are certain institutes where certain departments are lacking. So unless we don't put all those things together, we can't have a strong bridge of AMSP gapping all these things. Dr. Arvind needs a mic.
Learned a lot, sir. I've really, sir, excellent. One of the excellent talks which I have ever had. I will let me tell you very frankly. I was completely focused for last 45 minutes, sir. There is one comment from my side. क्लिक्स में पेशेंट सर कभी ना बेड साइड बोलते हैं, कभी-कभी सर आप हमारा दर्द कभी नहीं समझ पाओगे।
मैंने पहले बोला मैं आपका दर्द समझता हूँ।
नहीं तो
वेरी डिफिकल्ट फॉर यू, इवन आपके लिए एक्सटेंडेड इन्फ्यूजन करना बहुत मुश्किल काम है। तो बहुत मुश्किल काम है।
तो सर वो मुझे हमें लगता है कभी-कभी कि शायद मतलब हम भी अपना दर्द समझाएं कभी-कभी।
नहीं सर, आपका दर्द समझ में आता है, बिल्कुल समझ में आता है।
I was seeing that report, sir. So, treating a patient in a whole, with a patient of sepsis, septic shock in ICU with a focus, sample of which is already there with you, and very rationally, I mean, you have reported with attacks of some antibiotics which you feel that they should not be used. I mean, because that is what
Intrinsic
time says,
resistance.
yes. But many a times, sir, what happens that there are other things, other focus which keeps running in our mind. And at that point of time, once we have something written very clearly in black and white, so either we have to call you up that, okay, I mean, this is something going in our mind and we want to go above this, which is not there, or we can devise a mechanism by in the same report where you can put your own points, and then we can minimize that kind of, prolonging our decision making and you helping us. So that was first, you can have your comment. The second is, this graph, the beautiful graph that you showed, I mean, it was very kind of learning. I mean, the second graph showing MICs and time. So what if, why at this stage of time, we are giving carbapenems, let's say a 3-hour infusion or 2-hour infusion, 3 times a day, and why not to formulate it and give about 24 hours?
Yes.
So why it is happening then? I mean, this system of not giving about 24 hours, I don't find it.
Awareness.
Yeah.
Awareness. See, 3/4 of the hospitals in the world who are in like for JCI or their own in country accreditations, they are following these kind of extended infusion only. For those who read 2000, I think 18 or 19, there was a wonderful clinical microbial review, CMR, on extended infusion of beta-lactam. So if you see, most of the countries, they are following it. Unfortunately, that kind of knowledge is not there with the microbiologist. There's no coordination among the medical field, pharmacology, and the microbiology. We can all come back together and talk to you. Like when I was looking at ma'am, the ma'am had provided that case when piperacillin tazobactam 4.5 gram given us 30 minutes. So I took that with a pinch of salt. Why not? Why a pharmacologist is telling them they should be given us 3 hours. But I know it's difficult for them also to say, because clinicians को भी दिक्कत होती है to give a 3-hour infusion. It's very difficult. But if we can start following it on a routine basis, a routine clinical practice, जो मैंने आपको दिखाया कि you can reduce the burden by 1/3, you can reduce the cost by 1/3. जितना ज़्यादा देखो, मैंने आपको क्या कहा, bacteria they behave like humans, or humans behave like bacteria both ways. मैं आपको जितना डांटूंगा ना, आप उतने रेजिस्टेंट हो जाओगे. मैं जितना डांटूंगा रेजिस्टेंट हो, जितना बैक्टीरिया को आप ड्रग खिलाओगे उतना रेजिस्टेंट होता रहेगा. So why expose the drug to 3 times a dose where you can give only 8 grams per day? Right, so that kind of knowledge is not being shared. Even this I learned for the past 2-3 years only. I learned. So जब मैंने सीखा तो मैंने इसको implement करने की कोशिश करी. I try to disseminate it through on different platforms, and I hope that all the clinicians who can are there, who can see this thing or who can hear me out, please try and implement the practice of extended infusions only, of not less than. So we write not less than 3 hours. That typical word is going in every report. Not so there's a Word document around 50 pages I've made. जो आपने अभी reports देखी हैं उसमें, only the upper part comes out automatically. The rest of the part I'm customizing everything. All those things like Dr. Purva is the software. He said yesterday that you can customize it also, right? So all those things are customized, and we send it as a customized report. Every clinician in my institute knows that beta-lactams को extended infusion में ही देना है. About the yeah. See, what happens is, like I mentioned, ceftriaxone. Let's talk about ceftriaxone and ampicillin in Salmonella typhi. So अभी तक ये धारणा थी कि ceftriaxone देंगे तो अच्छे ट्रीटमेंट जाएगा, हो भी जाता है ट्रीटमेंट, कोई इशू नहीं है. But then I sat down with the clinicians, I told them that ceftriaxone MICs for all Salmonella typhi isolates is 1 that we get. Invariably you're getting as 1, not even 0.51. The breakpoint MIC is also 1. तो वो दोनों का रेशियो केवल 1 है. But ampicillin में क्या होता है, उसका जो रेशियो 4 आ रहा है. So ampicillin will achieve a much higher concentration in the blood as compared to ceftriaxone. So what we call as the mutation selection window. एक window होती है जिसमें it's an invisible window, जिसमें the mutant strains they get selected out if there there are certain strains with slightly higher MICs, the mutant strains. तो अगर ये gap wide रहेगा, तो उसका selection होने के chances कम है. So you are likely to get less therapeutic failure with ampicillin as compared to ceftriaxone, because ceftriaxone resistance is now for real in Salmonella typhi. So that is why we restrict the use of higher end antibiotics. We don't disclose it to them.
So, thank you, Dr. Sumit, for an excellent presentation. I just want to make a couple of points.
Yes,
one thing is that about the extended infusion, most of the data that have been generated outside, barring one study from CMC Vellore, I think, and one from ACTREC Mumbai. That is about the carbapenem, repeated infusion and prolonged infusions rather than continuous infusions. We have to keep in mind one important aspect, that is the stability. The stability is ICU to some extent, where the temperatures are maintained. You may not be so concerned, but there are other areas in the hospital where that can be.
That is one question which I also wanted to ask you: how do you maintain the stability of temperature-sensitive antibiotics?
So there are quite a few of them, and carbapenems would be important category. Second is the issue of our very ill patient. Critically ill patients where third spacing is occurring, we do not have very good information from those subsets, and that is something which is a work in progress. So, and third thing is feasibility, of course. So when Samiksha said 1 hour, because she knows the working of the ICU there, even 1 hour was an issue there. So from 2 hours, we said at least make it for 1 hour. Okay. So you have to be generating that evidence and then implementing. We can't be very
rigid.
Hospital setups abroad. Second thing is beta lactams. We should not all be putting them in one bucket.
Right.
We have to be categorical. For example, ceftriaxone and cefoperazone sulbactam. We need to treat them a little differently. So those are the points that are work in progress, and I think we should have, we will need to be a little patient about the data which are generated for them.
Thank you.
I have a philosophical comment.
Always.
Dr. Sumit is working hard for what Dr. Nusrat should be doing, pharmacology. Dr. Nusrat is doing what I should do, the clinical, and I am doing what a community medicine people should do, that is moving into community. My question is it by choice or it's a compulsion on us? Anybody of you can take it for that matter.
If it is a spiritual question, I'd say it's a divine intervention. Somehow it's a divine intervention. It's somehow no, nothing is a coincidence in life. Nothing is a coincidence. Something happened that I was able to interact with Dr. Ashish. I was able to read these things, and I landed up in an institute which does not have a pharmacology department. So by default, I went into this thing. So that's my part. So there's divine intervention. Probably you are able to communicate more with the administration. You have your outreach program, and your outreach viewpoint is much better than other people. So you can communicate better with the masses. So probably that's why you're into community medicine. So that's what I can guess. It's probably a divine intervention.
Thank you so much, sir, for enlightening us with your knowledge. I would request Anup Kumar sir to come up on stage and please hand over the memento to Dr. Sumit Rai sir.
It is heartening to note that ASPCON 2021 aims to serve as a platform where medical institutes from India can gain and share their experience and ideas on antimicrobial stewardship. We request Chairperson Dr. Anup Kumar, Professor and Head of Department Orthopedics, to explain the rules of the session. Please, sir.
Good afternoon. So next session is integrated antimicrobial stewardship practices and experience sharing. So we have 7 teams here, 7 groups which will be presenting their experience, but there is a restriction of time. So we'll give a warning. The presenter will be presenting for 8 minutes and 7 minutes. At 7 minutes, you'll get a warning to wrap up your thing, your experience in the next 1 minute. So 8 minutes is your allotted time, and then we'll have about, if time permits, 2 minutes of discussion. So I would request all the teams to stick to the time frame. And we have 7 teams which are from PGI Chandigarh, AIMS Jodhpur, AIMS Bhubaneswar, AIMS Rishikesh, AIMS Raipur, College of Medicine and Healthcare Sciences, Sultan Qaboos University, St. Helen and Knowsley NHS Trust. So we'll call upon the first team from PGI Chandigarh, and we have some teams which will be on an online mode, some team is on offline mode, and we have 3 teams which are on a hybrid mode. Some representatives, some speakers will be online and some will be offline. So they have to manage their time within that 8-minute time frame. So I would request the first team from PGI Chandigarh, Dr. Ratin Mohendra, Assistant Professor, Department of Internal Medicine, to share his experience. Dr. Ratin Mohendra.
Good afternoon, everyone. I'm Dr. Ratin Mohendra. I work as an assistant professor in the Department of Internal Medicine at PGI Chandigarh, and I'll be sharing about our experiences at PGI Chandigarh. So, like most other places, we work in collaboration. We have 2 different committees which collaborate. We have the Hospital Infection Control Committee and an Antimicrobial Stewardship Committee, which I would be talking about in my current presentation. So currently it is being chaired by Professor Vanita Suri. She is from gynecology. We had a surgeon previously handling the chairmanship of the committee, but he just superannuated. And the convener is Dr. Nusrat, who is also the most powerful force behind the working of this committee. And it's a multidisciplinary committee where we have medical microbiologists, we have people from pulmonary medicine, we have people from pediatrics, hospital administration, and we have a few invited members from clinical pharmacology. And I happen to be the most recent new joinee to this group. Besides this, we all have every clinical department has a nodal person who's been appointed by the head and to coordinate the activities related to the AMS. So it all began way back in 2013 when there was an expression of interest from the fellow clinicians that we need to have AMSP as our main goal. And in 2013, informal survey of antimicrobial prescriptions was done in the hospital, and we decided to set up a system which was specifically tailored to the peculiarities of our health system, where we have all these problems. In 2014, we started having combined rounds with the respiratory ICU, which was later on expanded to all other ICUs. In 2015, guidelines for surgical prophylaxis were made. It started from the cardiothoracic and vascular surgery department, followed by the urology, followed by the obs-gynae department, and was then expanded to all surgical specialties. The baseline data was collected by the clinical pharmacology residents, who proposed a modified plan after concurrence with the faculty members. And follow-up was done, and we showed that there were no adverse outcomes if they reduced the duration of the surgical prophylaxis. And the data was again presented to the stakeholders. The guidelines were made and disseminated in a CME, Surgeons for Rational Use of Antimicrobials, in collaboration with the NCDC, WHO India, and different surgical societies. In 2017, we started having dedicated sessions on antimicrobial use, which were case-based discussions, teaching sessions, bedside rounds, involving the different departments. It started from the respiratory ICU, then we went on to the main ICU, the neonatal ICU, the trauma, surgery ICU, pediatrics, and now we have recently started having rounds with the emergency and the transplant ICU. The focus was on surgical prophylaxis and stopping prescriptions using double anaerobic cover. A similar model was then followed and we developed guidelines for all ICUs. In 2018, we did the first PPS in PGI for the use of antimicrobials, and based on our learnings from that, in 2019, we collaborated with 4 other centers and we did a PPS on the global PPS model. So what have we learned in our journey? We have tried to set up models which others can possibly follow. We try to provide inputs at the state, national, international level for setting up various plans and policies. Our emphasis is on training and community outreach at different PHCs and district hospitals for prospective audit and feedback. And we try to improvise certain approaches, like we try to adopt a dual strategy where we took into account the IPC practices and AMS practices together. And we did PDSA cycles, especially in our disaster ward, where patients were followed up totally from the initial point of entry to their final discharge. And in 2020, exactly a year ago, that is on 4th December 2020, we released this antimicrobial policy, which was for PGI, and it was for all our OPD and IPD patients. The ICU guidelines were already there. They were published in 2017. So for troubleshooting, we usually have our clinical referrals, which are seen by a clinical pharmacology resident who then gives the feedback. And we try to employ a dual strategy where IPC and AMS work hand in hand. And for difficult cases, we have a multidisciplinary team approach and meetings. However, despite our vigorous audit and feedback, we were still not able to fully reduce the use of high-end antimicrobials as we would want. And our AMR is still a little high. But we have been able to reduce the irrational prescriptions. So innovations, we have started having prospective audit and feedbacks. A duty resident of residents of pharmacology is made who look after different areas, and there's a logbook that they have to maintain. A digital system for record keeping and analysis is in place, and we try to adopt the PPS methodology, and for data collection we use the EpiInfo. And we have now piloted a rational assessment tool, as already discussed in the morning session. So this is what our feedback form looks like. And we have incorporated the form into the patient files. This is how our feedbacks are being provided through WhatsApp. And this is our digital system for record analysis. So it can incorporate data regarding susceptibility. It can generate report on different matrices. We can incorporate filters into it and can be web enabled. However, there's a disclaimer that we are not able to use it fully because where we lack is we have less data entry operators at our place. So we are not able to fully utilize this. So in our innovations, this has already been talked about. What is the way forward? We look to continue to strengthen our existing AMS systems. We want to frequently hold training sessions and continue our hand-holding in AMS. Further expansion of our community initiatives, becoming partners in One Health approach, continue our advocacy against the irrational antibiotic prescriptions, especially the fixed drug combinations. And we have tried to focus on availability of essential antibiotics, which has been beautifully brought out in this paper just published in BMJ Global Health. So finally, I would like to conclude that antimicrobial stewardship in our place, like all other places, is a multidisciplinary activity where we aim to decrease the antimicrobial consumption. We try to use the antimicrobials rationally, and we try to decrease the MDR pathogens and decrease in the cost of treatment. Thank you.
Thank you, Dr. Ratin, for finishing it in time. So I would like to invite questions from the audience. Any questions? If no questions, then we move on to the next institute. That is from AIMS Jodhpur. And I would request Dr. Akshata to present case, and Dr. Jagdish P. Goyal, Professor Pediatrics, would be online.
Good afternoon, everyone. So, I would like to present the experience of AIMS Jodhpur in this regard, a way forward on integrated antimicrobial stewardship practice. Actually, this was supposed to be presented by Dr. Jagdish Prasad sir. So, along with sir, we have other prominent members in the AMS team, which includes from various departments, including microbiology, pediatrics, pharmacology, anesthesia, neonatology, pediatrics, and so on. So till now we have screened around 2,670 patients, out of which 787 patients were on high-end antibiotics, and out of which we can see the death rate was around 24.5%. So in our AMSP practice, we have covered these basic topics, that is antibiogram and the antibiotic policy, antibiotic de-escalation, and whether the patient was on definitive or empirical therapy, and the TDDs. And for the AMSP, we have currently only one research associate who is covering the ASCU, PICU, and NICU. So this is the antibiogram which we have obtained so far. For E. coli, in our institute, sensitivity pattern, most sensitive antibiotics were to nitrofurantoin, meropenem, amikacin, piptas. Klebsiella were more drug resistant, and in that, more again amongst the sensitivity, it was amikacin, meropenem, and piptas. For Staph aureus, around 50% of our isolates are MRSA, and among the sensitivity was susceptible, more sensitive to linezolid, cotrimoxazole, clindamycin. Acinetobacter, again, more of MDR strains which are obtained in our institute, and more sensitive were to your meropenem, levoflox, and piptas. This practice, we were through the AMSP, we were able to achieve the significant de-escalation, which was around 64% in Jan 2020, which has improved to 81.7%. And de-escalation we have considered as stopping of the antibiotics within 5 days, or changing of the combination to monotherapy, or change to a narrower spectrum, or conversion from IV to oral. For the next parameter, we have significantly increased the percent of patients who are on definitive antibiotics from 66% in Jan to 78.9% in September 2021. And the significant use of carbapenem derivatives, there is significant reduction from 67% to 50% in September. And colistin, which was around 33 to 40%, it has reduced to 31%. And also we have started increasing the use of the inhalational or nebulization of the colistin. So the challenges or the trouble which we found is the lack of funding and the manpower, and lack of collaboration between the different departments, which has been emphasized in this conference. And again, the controversial in regarding the de-escalation of the higher antibiotics, and lack of awareness regarding the restricted antibiotic usage form. And to cater for all this, it would be helpful if we can, we have to appoint more and more of clinical pharmacists to continue this AMSP activities. As such, we have only one clinical associate in our setup. And to make the clinicians aware about this antibiotic burden in each steps, and to make sure the people, even the common people, are aware of about the self-medications of with the antibiotics. So concluding, this we have, it is necessary that this hospital antibiotic policy is updated from time to time, and we have to implement this AMSP as an integral part of our daily life, daily clinical practice, and not just as a part of this 3 years duration. So with that, I would like to end.
In the meanwhile, any questions from the audience? Yes, Professor Jagdish is here. Any question from the audience? Okay, thank you, Dr. Akshata, for your presentation. So we move on to the next team to share their experience. It's from AIIMS Bhubaneswar, and Dr. Prashant will be presenting, and Dr. Anupam De, additional professor and HOD medicine, would be online.
So Dr. Anupam sir is in the Zoom, so he will be starting the section. Dr. Sir.
Yeah, thank you. So I'll be presenting the way forward on integrated antimicrobial stewardship activities and experience from AIIMS Bhubaneswar. With me is Dr. Prashant. He is senior resident from Department of Microbiology at AIIMS Bhubaneswar. Next slide, please. So the team at AIIMS Bhubaneswar consisted of me, then the microbiologist, Dr. Bijayani, who is an additional professor in microbiology, Dr. Jawahar Pillai, who is an administrator, is additional professor of hospital administration, Dr. Bisuman Pari, he is additional professor in pharmacology, Dr. Tushar Misra is a professor of general surgery, and there's a clinical pharmacist who was working with us. He is not with us anymore now. And we had the team, we carried out the antimicrobial stewardship activities. We'll share the experience of 1 year, and I'll hand over to Dr. Prashant to carry on proceedings further. Dr. Prashant, please.
Thank you, sir. So I will be discussing our AMSP journey so far. So we created the objectives of creating an antibiogram for the hospital and using that to create an antibiotic policy, which includes surgical prophylaxis too, and to carry out antibiotic consumption in 2 ICU and 2 wards, and also calculating the drug consumption using a defined daily dose and duration of therapy. Then audit for reserve antibiotics, including formulary restriction for selected antibiotics, were also done. Then point prevalence was done for culture of cultures, and occasionally educational work and feedback regarding AMSP was taken. So antibiogram was done based on the bacteria obtained from the site and also from the location like ICU, ward, and OPD. And using this antibiogram, we formulated an antibiotic policy, which is drafted in regular basis. Currently, we are using version 2. So this is an example where all the important infections are covered and what are the empiric therapy to be taken. Then for the consumption of antibiotics and the usage, we had created a form where the resident or the doctor posted there has to fill all the particulars and what type of patient, whether recently contacted the hospital, whether he went through invasive procedure or the long duration stay in the hospital, and also the organ system involved, and what is the mode of treatment the antibiotics has been started, and also when it is started, what is the dose and frequency, the start and end date, and what is the justification for starting. So all has to be filled. And behind the page, there was a de-escalation tracking usage, where after culture and sensitivity is obtained, whether de-escalation was done or not. So for the antibiotic consumption, these are the 2 metrics we use, that is defined daily dose and days of therapy, which is also recommended by WHO. And there is a tool available online also, which is provided by WHO and can also be calculated manually using this formula. It is also available online. So I'll be just skipping through these slides. And for audit for reserve antibiotics was done by visiting the treating unit and asked to fill up the form, which I showed previously. And formulary restriction was carried out for colistin and other polymyxin, which was done by approval of the unit head. Then point prevalence of cultures was done. So randomly we used to go to the ICU and we at that point of time, how many samples were sent and how many people were on the antimicrobials or as therapy or prophylaxis. And we used to see how it was the ratio. Then the 1 year experience, this is the quarter-wise statement of 1 year activities. In Q1, we did the antibiogram and formulated the antibiotic policy. And carrying out antibiotic consumption in ICU was done in all the 4 quarters. And audit also was done in all the 4 quarters. And point prevalence of culture was done on 2nd quarter onwards. Then education work and feedback regarding this AMSP was also done in all the 4 quarters. Then these are some of the data of the 3rd and 4th quarter. So because of this defined daily dose and duration of therapy, we were able to establish a trend in the usage of in these particular areas. And we could have a check that whether the consumption is more or less. So then also the point prevalence was done, that is by bacterial culture rate. So we used to go in particular days unannounced and we used to check the number of patients and number of cultures sent. So the ratio year 1 is a good, and anything below 1 would be considered as non-satisfactory. So educational feedback was usually done, and this is one example where in second quarter, Anupam sir was taking a presentation on biomarker-based antimicrobial stewardship in clinical practice. So for way forward, I would like to give it back to Dr. Anupam sir, where he can discuss this idea.
Thank you. So the way forward is we would like to expand this AMSP to more wards. We have already seen over the last 2 days. So nice work going on, and we'll definitely like to expand this to different areas and more ICUs. A very important thing that we'd like to focus on would be a feedback mechanism. We have seen very good examples of how feedback is being given. We'd like to do that. We'd like to expand that. Then training and education programs is a continual process, and that will continue in the days ahead. What is important, I believe, is incorporating this stewardship idea into training curriculum, and maybe also into the into teaching curriculum of students, so that they come to know from the very beginning that we need to handle antibiotics with care. That is something maybe we should look into. And the institutional targets and evaluation framework is very important. Some institutes have already done that. Commendable job we have seen over the last 2 days. We would definitely like to do that in future, have our own targets. And of course, one more important thing is to make champions, institutional champions, and even award the champions for good stewardship work that will spread a culture of adopting this. Next slide, please. So to conclude, this integrated stewardship is the need of the hour, and we need wide dissemination. And as AMSP team members, we definitely have a huge responsibility to shoulder. I'm thankful to the committee for giving us the opportunity to speak here, and I've learned a lot from the last 2 days. I thank everybody for sharing the experiences. Thank you. Any questions, please?
Thank you, sir.
Any questions? Thank you, Dr. Anupam and Day and Dr. Prashant.
Thank you. Thank you very much, sir. Thank you for providing the opportunity.
Next, I would like to call the Institute AIMS Rishikesh and Dr. Prasann Kumar Panda, Additional Professor and HOD Medicine, would be presenting it. And online would be Dr. Gaurav Chikara, Associate Professor Pharmacology, Dr. Santosh Kumar, Associate Professor CFM, Dr. Ambar Prasad, Associate Professor Microbiology, Dr. Rakhi Mishra, Associate Professor, College of Nursing. Thank you.
Again, good afternoon to all. And from AIMS side, one correction actually I want to tell. I am not the HOD. I am the associate professor and heading infectious disease as a head, I can tell, in the Department of Medicine. And three of us will share because two are not available because of work. I will just actually brief tell the last our three parts. One, Dr. Gaurav Chikara, the pharmacology, and Rakhi Mishra, the faculty of nursing. Actually, she will be present on this part. And what we have developed, actually learned till now, last actually 4 years since 2018, we are focusing on this part of workflow of integrated antimicrobial stewardship. इसमें सिंपल चीज यही है कि पेशेंट जब हॉस्पिटल में आता है उसके बाद उसको क्या क्या हम करते हैं, ये सभी इसी डायग्राम में डिपिक्ट किया गया है और ये हमारा शासकीय वेबसाइट में भी है. This is the ideal for us and we are trying to implement all the aspects, but till now I will tell actually what we got. 2018-19 in the first from Aspicon 2018 to 2019 the AIMS Bhopal, we achieved that time among these 7 component of antimicrobial stewardship core elements as per CDC. Leadership commitment, it was there 70% and 23% from the support, and that increased to averagely 80% till now in the last 2 years, because 2020 we could not do a conference. Therefore, I will share the data of last 2 years. Accountability, it has increased from 27% to 40%. Drug expertise, it remains same till now. हमारा pharmacologist से इतना same support मिला है, and we are trying in the next year it will increase more. Few actions, intervention, definitely it has increased the compliance part. पहले 29% था first जो 2018-19 में, but अभी ये 50% हुआ है. And tracking part of antibiotic utilization and also diagnosis part, it also increased 40%. And reporting part, it decreased because of COVID issue, we can tell. And हमारा institute एक COVID declared हॉस्पिटल है. And education part, definitely we have increased a lot towards the nursing part and also healthcare doctors. एक पार्ट 6 स्टेप मॉडल जो मेरा फास्ट कल में प्रेजेंट किया था, तो उसमें ये चीज है कि जो हमारा इंस्टीट्यूट का कोर पार्ट है, बिकॉज अल्टीमेटली बिफोर द राइट डायग्नोसिस मेड एक्चुअली, तो डायग्नोसिस ऑफ द नेचर ऑफ ऑर्गेनिज्म टू बी डिसाइड, दैट इज पैथोजन और नॉन पैथोजन. वी हैव डेवलप्ड ए कल्चर फॉर्म इन दैट. इसमें 6 स्टेप में जो बताया था कि पहले लोकल साइट इन्फेक्शन है कि नहीं है जज करते हैं, फिर सेप्टिसेमिया है कि नहीं है जज करते हैं, ये ऑर्गेनिज्म जो ग्रो किया, इज इट द नॉर्मल मोस्ट कॉमन ऑर्गेनिज्म टू आइडेंटिफाई द सोर्स ऑफ इन्फेक्शन दैट साइट और नॉट. कमेंसल फ्लोरा क्या होता है उसी साइट ऑफ जो पैथोजन जहाँ पे सैंपलिंग हुआ था, एंड एनी होस्ट फैक्टर था जो कॉलोनाइजर को पैथोजन बना सकता है, ये भी हम डॉक्यूमेंट करते हैं. तो इन दैट बेसिस वी फाइनली डिसाइड कि ये पैथोजन है या नॉन पैथोजन है. नॉन पैथोजन वी एक्सक्लूड, डोंट गिव एनी ट्रीटमेंट, बट पैथोजन है देन वी स्टार्ट ट्रीटमेंट. इसी ट्रीटमेंट में वी आर डूइंग एट दिस स्टेज. नाउ आई वेलकम डॉक्टर गौरव चिकारा, जस्ट अभी रिसेंटली एक्चुअली ज्वाइन हुआ है, मतलब इन द सेंस कि आवर एंटीमाइक्रोबियल स्टूवर्डशिप पार्ट. एंड डॉक्टर गौरव प्लीज.
Good afternoon to all. Am I audible?
Yes, go ahead.
Okay, so I'll be covering the pharmacy aspect of the stewardship program. Along with the pharmacology department is already doing or contributing in the integrated stewardship program by giving the experts' opinion when and where required. Now, in addition to that, we have tried to intervene through the pharmacy side as well. And during the pandemic, as we were facing the similar situations, the national guidelines were getting revised very frequently. It was a dynamic state. And so an important thing, we were able to update those or integrate those guidelines into the Institute's antibiotic policy. So thanks Dr. Panda for that. He was actually doing that in the real time and circulating to all the stakeholders. Now, we were constituting, updating, circulating the guidelines whenever required and whenever early as possible. But that is one aspect that doesn't ensure implementation. So we have, in addition to that, delegated authorities to various faculty members, to the nursing staff, to the faculty members of the nursing colleagues or within the medical colleagues. And they were given the role in parallel to their usual practice in the hospital to control the prescription of the experimental therapies in particular. Though it was to be done for all the reserved antibiotics and high-end antibiotics, but in the pandemic, we were more focused, you can say, on experimental therapies, because the name of experimental therapies, be it remdesivir, be it tocilizumab, be it favipiravir, it was on the tongue of each and every, not only the medical fraternity, nursing fraternity, but also the layman person. So we have to counter that stress on the treating physician, so that it doesn't subject to the demands and pressures of the attendants and all. Now, along with that, in Uttarakhand itself and along with other few states, there was a guideline regarding the use of antibiotic combinations. So that was not practiced by the institute, and because it lacks rationality. Then from the pharmacy side, we actually initiated UHID-based dispensing of the medications. So it was done, digitalization was done, as was emphasized by Nusrat ma'am. And with the help of digitalization, we used to dispense on the UHID basis, unique ID for each patient which is admitted in the hospital. And by this, we can track in the real time the dose duration and the change in the antibiotics or antimicrobials wherever possible. Sir, could you please go to the next slide? Yes. Then along with that, the central pharmacy or the senior pharmacists were cross-checking all these things, and they were giving feedback to the concerned authority, and in particular to reserve antibiotics and experimental
Dr. Gaurav, because of shortage of time, actually, I will conclude.
Yes. Okay,
Committee we have developed, actually, these are few committees actually we have all in place. And just I request faculty nursing actually in charge, Rakhi ji, to have a just not stewardship, because it is one part actually we did it the good way, like as a clinician. Just 1 minute. Rakhi, please.
Okay,
Thank you.
Sir. Am I audible?
Yes, go ahead.
Am I audible, sir?
Yes.
So during this World Antimicrobial Awareness Week 2019, 2020 and 2021, we have kept a stepping stone to develop nurse stewards in our institute. The World Antimicrobial Awareness Week 2020 event had workshop, bedside icebreaking IAS session on integrated antimicrobial stewardship practices to create training for trainers among nurses and residents. One area was declared as IAS Champion 2021, who was following integrated antimicrobial stewardship practices. A plan is to further carry continuous training come assessment at every 3-month interval for all healthcare workers. Next slide. So previous slide.
Yes, last. I am concluding actually.
Okay.
The that part actually what Rakhi was telling in that part ki we have make a integrated antimicrobial stewardship champion, that actually that AIMS Bhubaneswar actually telling ki we'll focus on that, but the time has come actually all the institute actually should do that. One area has to give a for particular year, and to after 2021 then again 2022 again it will be assessed. Our simple target is this: 0 hospital acquired infection by 2022, and 6 vaccination to all the healthcare workers who are working there, and source control not for the peak MDR, it should be all MDRO, and cumulative anticrime for the real MDR pathogens. Thank you.
Thank you, Dr. Prasann. Any questions to be asked for their experience part? Okay. Thank you. We move on to the next team. It's again, it will be a purely online from AIMS Raipur. Dr. Padma Das, Professor of Microbiology, will be presenting.
Thank you for introducing me. And actually, very good afternoon to all the participants, and happy congratulations to the organizers. Should I share my presentation now?
Yes, madam. Please go ahead.
To start with, many thanks to the organizers, and I had been in the WhatsApp group previously also, and I wanted that these things to prosper more. And Dr. Prasanna, Dr. Sagar, Dr. Vinod, they have all made it possible at least. So thanks to them again. And to start with, AIMS Raipur, which started, it is a new institute started in 2012 or 13. We started our microbiology facility in 2014 December, and we had a project, AMSP project. Now the committee is expanded, and whatever we felt that relevant, we included the persons from head of the departments of clinical departments like surgery, pediatrics, microbiology, medicine, neonatology, and the ICU in charges also, where we can just do the things perfectly. And here, along with me, Dr. Tushar is there, which actually he does the clinical stewardship. He has a lot of role in it also, and he is the additional professor of Department of Pediatrics of INSTITE. We have now included pharmacy also. So, according to this AMSP programs, what are our accomplished targets so far? What we found to successfully perform? One is from the microbiology department, we are doing the yearly antibiogram preparation from the 2017. It is a stratified antibiogram according to the location of patients, like ICU, IPD, OPDs, and also according to the organisms also. So here also one good thing about it is that all the reserve antibiotics are included. We have included almost all. We taste them routinely. We don't report, but we taste. And important drug resistances are mentioned separately, and it is as per CLSI norms. Antibiotic policy development has started. We have our own antibiotic policy. The antibiotic policy committee. Antibiotic policy committee is actually the lot of efforts from Dr. Gaikwad is there. He is the pharmacology professor in pharmacology, and he has done a lot of things regarding this.
Ma'am, your slides are not visible. Now it's moving.
Now it's visible?
Yes, yes. You can put it on PowerPoint on a slideshow.
So he has a lot of role in antibiotic policy development with the antibiogram. We had to sit together with the clinicians, and we used 2 years antibiogram to make the antibiotic policy, which was approved by the head of the institution, and it was circulated among hospital doctors. They are also abiding by this now. Cultural cultures, it started as a project part, and now we are doing it also. It is a point prevalence study here. We find this actually ratio as the bacterial culture rate here, adherence to sending of proper bacterial culture sensitivity before administration of antibiotic. We have to measure by that, and this is the rate. Now it is already 100% in these 3 ICUs which we have measured. So now also we find a collaboration between the clinician and the microbiology department also. So antibiotic consumption rate, we are doing DOTs. We are not going for DDDs. A lot of problems are there, and DOTs in the ICUs, 4 ICUs we have done. And to do that, we have appointed a pharmacist. Administration has given us. So here the days of therapy in all about the carbapenems we have done. Here this is the days of therapy of each ICU. It's a table also. So we have done in the institutional AMSP committee, we have included hospital pharmacy in charge also. He is assistant professor of pharmacology, Dr. Kuba Johnson. He is there to attend the CME in offline. And we have done for staff education, a national online workshop was arranged, as well as for the institute also, for the hospital staff. And in the daily clinical discussion for the culture positive reports, we do a daily clinical discussion with the concerned physician or clinician. And here also we give a lot of sensitization about the antibiotics also. Then coming to the support provided by microbiology laboratory, we are mostly dealing with quality specimen collection and appropriate testing. Implementation of rapid microbiology diagnostics, proper antimicrobial susceptibility testing, and antibiogram generation. We have automated blood culture systems and automated identification and AST systems. In future direction, that is in the process now, Maldita we are going to receive now, and we are so for primary testing and routine reporting of group A antibiotics, which are routine group of antibiotics, we report, and we always go for selective and cascade reporting of reserve antibiotics. And in these cases only we report reserve antibiotics. But we taste all the antibiotics for antibiogram purpose, and we place it in Pune supply. Taste to rule out bacterial infections like biomarkers, procalcitonin and fungal markers, galactomannan are done routinely. But in our future direction are to go for rapid viral testings like rapid antigen detections for respiratory viruses, rapid immunoassays, and for other biomarkers of sepsis, as well as non-culture based fungal markers like molecular beta-glucan and single or multiple pathogen PCR for fungal detection. communication of investigations are done. Key findings are always reported. Branston of like positive blood cultures, culture positive smears. They are always reported directly to the clinician because we have always confirmed, ensured that in the TRX test requisition forms, the clinician number should be there. So we directly report them, and critical reports are always informed in the real time, in the night also. Unusual pathogens, intrinsically resistant patterns are always communicated to the clinician. Comments added to the final reports are intrinsic resistances, pathogenicity potential, and spectrum of disease. And we have a round-the-clock laboratory facility. It started from 2018, and we have facility to receive and process specimens and reportings of important findings. We have a collaboration with institutional HICC for implementation of infection control measures and surveillance and controls of outbreaks, HAI outbreaks. So we do the AMR surveillance using Untitled Chapter. We prepare the hospital antibiograms and active participation in framing institutional antibiotic policy. We sit together with the clinicians and we frame the antibiotic policy. And we have now implemented a quarterly microbiology newsletter, and to make everybody aware about the current trend of antimicrobial resistance, and it is circulated to clinicians, all senior residents, junior residents, and nursing staff also. We have future targets like it is on process.
Madam, please wrap up.
Procurement of malware to reduce turnaround time and targeted antimicrobial therapy. We want to go for a genotypic resistance elimination so that we can target the antimicrobial therapy. And therapeutic drug monitoring of reserve antibiotics, these things we are not ventured also. So we have to do this. Formulary restriction for reserve group of antibiotics, again, we couldn't do it because a lot of opinions are there from different people. So gradually we are trying to do it, and we have to addition of other ASP indicators, process indicators, as well as outcome indicators we have to add. This is our future target. So thank you. Any questions?
Okay. Thank you, madam. Any questions for Dr. Padmadas, Professor Padmadas? Okay. Thank you, madam. There's no question. So we thank you for your presentation.
Thank you again, everyone.
Next, we move on to the team from College of Medicine and Healthcare Sciences, Sultan Qaboos University, Oman. Dr. Meher Rizvi, Associate Professor Microbiology and Immunology, will be presenting it online.
A very good afternoon, everyone. It's such a pleasure being with you. I hope I get the host facilities quickly.
Good afternoon, madam. You can start your presentation.
Yeah, I'm just waiting for the the signal that I can share my screen. Yes, I can. Thank you so much.
Okay. It's visible.
Good afternoon, everyone, and felicitations to Dr. Bhaskar for organizing this absolutely splendid conference. I'd like to, just my particular presentation is slightly different because he is a very important member of this prospective multicentric study which aims to promote antimicrobial and diagnostic stewardship in the management of UTI, which has been nicknamed DASH to protect antibiotics. So do bear with me. We have over 41 centers spread over Middle East, Indian subcontinent, Eurasia, and Africa, and we've been experiencing unprecedented regional cooperation over the last 1 year. Just to give you a little idea about where I come from, we have a restricted formulary. There is no over-the-counter sale of antibiotics. There's a pretty good adherence to guidelines, including AWARE, as far as the reserve drugs are concerned. There is a relatively good flat hierarchy, which means that behavioral changes are easier to institute, which is a big plus. So as you can see down the list, the systems are very much in place, but the area of concern which concern me and all our other partners is that the majority of antimicrobial stewardship activities are relegated to the inpatient, which is absolutely correct because of the high broad-end drugs and IV drugs. But the issue which concerns me is the large quantum of antibiotics which are used in the outpatient department, and that far exceeds the usage in hospitals. And that's an area crying for attention, primarily because that's a hotbed of antimicrobial inappropriate antimicrobial prescribing, plus market-driven prescribing, plus academic detailing being done by the medical reps. And that's where I feel that we need to enter that space and use it appropriately. So the focus in our study is the top bacterial infection in most institutions. That's with the UTI. Most of them are managed on the ambulatory basis. And as you can see, the majority is with hardly any resistant markers. So this is an antibiogram, which is actually really beautiful when I see it from the Oman perspective. But even here, you can see there's an area of concern, that's ciprofloxacin 71. So despite all the systems in place, we're seeing that we need to promote fluoroquinolone sparing and third generation cephalosporin sparing strategies on a war footing. And we want to promote the drugs which have low collateral damage but excellent coverage, like nitrofurantoin, potlimoxazole, pivmisinlamab available, fosfomycin if available, or the lower cephalosporins if available. And you can see the beauty that they work against ASBLs and AMCs, and to a great extent even other MDRs. So the intervention that we're doing is requesting our clinical colleagues to send us appropriate samples that is community acquired. So we build the appropriate antibiogram, which is representative, and we don't skew the antibiogram towards greater resistance. And we will also be promoting mixing or heterogeneous use of antimicrobials so that we don't give the drug to the bug on a platter. And we don't encourage to develop resistance in real time. We confuse it and we say that let's start giving a mixture, heterogeneous use of antibiotics. So just from my own perspective, sitting in Oman, what is important is that one needs to have a word of caution about adherence to Western guidelines. They're very well for the places they are built for. We need to tailor them to our own needs, to our own ground realities. And blind adherence does put a big caveat on innovation, and that's something which we need desperately in this world, more so in LMICs. So that's where I would like to just bring in these IDSA guidelines meant for America and should not be blindly followed anywhere else, or even wherever they originated from. Would not recommend these at all in the settings where we are situated. And the idea is to adopt what is relevant, adapt some, and abandon the others. And here the role of microbiologists in tandem with the prescribers and the pharmacists cannot be overemphasized, and it needs to be done in such a fashion. Just a little concerns again in the Middle East and also in Europe and America, the fear antibiotics too strong, where I feel LMICs are far luckier. They have a huge arsenal of BLIs which they can use. For example, we don't even have ciprofloxacin sulbactam, which is an excellent buffer drug, which is a piperacillin tazobactam sparing drug, and which is something which India, for example, is very lucky happening. But in India or in other LMICs, we need to really spearhead a campaign against substandard and spurious drugs. We need to also explore combination treatments, say carbapenem sparing, colistin sparing, for just the simple reason of protecting them, and also because the populace cannot afford it. And finally, of course, go in a big way in expanding the One Health concept and promote extensive networking so that to break down the walls. So the microbiologists need to leave the labs and move into the clinical side and dash to protect antibiotics. And here I welcome Dr. Bhaskar to absolutely welcome all other teams to also be part of this study and move forward. So the study which you're doing is you're going to be interacting with all the departments over the whole year. And just to bring things in perspective, WHO Guidance 21 is also an evolving guidance for LMIC, has brought education center stage. So the area we're going to work on is the seminar room, where we have the HOD down to the intern right there. And we have a very interesting question I'll just come to. So we're going to work on the diagnostic stewardship, where we want the clinician to be as passionate about the quality of the specimen as we are, and we build a nice team group-based analysis of the questionnaire and share the focus antibiogram and then a good wrap up by the end where we do the feedback and the post-test questionnaire. And finally, the clinical lead gives the right appropriate guidelines so that a consensus can be built, which will be followed subsequently. So the questionnaire is a very interesting questionnaire, which has a small, simple vignette. I'm just giving you an example. So the prescriber has to think of not just the first choice, but also what will be the second, third, fourth, and finally we come to what should not be used. And we bring in the principles of antimicrobial stewardship here as to whether it's PK/PD, is it drug interaction or a contraindication or an allergy, or is it because the drug is too broad spectrum or there is resistance. All that will be built into this. And we want to promote reflective and not reflexive prescribing. And that will bring in the buy-in and the engagement from our prescribers. We'll be relearning a lot of stuff, we'll be unlearning a lot of stuff. And through this, we also want to build these into our curriculum so that this becomes a guidance for application of these scenarios so that we can continue evolving together. And of course, that means it has to be integrated. And while we are fine-tuning our dosing, what is very important again is that when I'm trying to bring in a dose which is mutant preventing concentration, and thus we circumvent the mutation selection window, are we precipitating sepsis by using bactericidal drugs because of the release of the endotoxins? Are we considering the inoculum effect? So all this will be discussed and hashed over the next 5 years. And this is the way we plan to go about it. Simple UTI, it's in the comfort zone of everybody. And then we move beyond that to the sparing, as I told you about the sparing protocols for carbapenem, colistin. We will be ensuring that we empower our nurses not only in IPC, but also in antibiotic de-escalation, vis-a-vis IV to oral switch, vis-a-vis antibiotic timeouts. And then we also interact with the intensivists in the 4th year, and we come back to the biggest stakeholders, which are the patients, the citizens, and the media. And we enter a discourse with them about deferring antibiotics or non-antimicrobial, in fact, antimicrobial sparing protocols and symptomatic management. So the idea through this study is
to
that
wrap up, please.
Yes, I will. This is the last one. Empiric teamwork is where we bring in the prescriber with the pharmacist and the microbiologist together, developing the empiric choices so that nobody is alone, and we build appropriate prescribing policies with bringing in restricted formulary, which makes things so much simpler. Thank you so much. It was a pleasure being here.
Thank you, madam. So, any questions? Thank you for joining, madam. Now we move on to the last online presentation from St. Helen and Nolsky NHS Trust. Dr. Ishra Halim, specialty doctor in microbiology, would be presenting.
Good afternoon, everyone. Can you just confirm if I'm audible, please?
Yes, you are very much audible.
All right, thank you. Good afternoon, everyone. I'm Isra Halim. I'm working as a specialty doctor in England. I've just shifted very recently. What my presentation is slightly different. It's basically a summary of everything that we've learned in the last 2 days. And I'm just going to put it as how we practice AMSP at every level in a normal workday in England. My slides are not moving. Okay, I'm not going to go through the aims, and I had a couple of cases which have already been discussed earlier today. So everybody knows AMSP more than I do now. A normal Monday in the life of a clinical microbiologist in the UK, we have regular 9 to 5 weeks with weekend on-calls, but they're very intense days. We start with validation of reports. So the clinical microbiologist, like in India, we have a big role in restricting antibiotics, in deciding which the pathogen is from the colonizer and all of those. But we follow very strict guidelines. So every hospital has their own guidelines based on things called micro guide. So these are app-based guidelines, which are tailor-made to our hospital. And we follow the BNF for dosing. So as a microbiologist, our reports not only contain the organism and the sensitivities, but also any extra dosing requirements. We need the team to know if fluclox is not very good for a group B streptococci. It's the role of the microbiologist to actually put everything as a rider in their comments. Most of us are already doing that in India as well. The rest of the day is either ward rounds or on calls. So no antibiotic can be prescribed in the UK without the advice of a clinical microbiologist. So we either go on site or we receive calls from all hospitals. My trust covers about 4 hospitals. So we need to take calls from everybody or have dedicated rounds, specialty rounds, and decide on the antibiotics. I will say how we do that in my next slides. And the most intimidating part of everything was everything needs to be documented. Any clinical decision that a microbiologist makes has to be documented, whether you have given an IV or an oral, or if the patient has refused antibiotics, or if a certain clinical team has not stopped antibiotics on your advice. So all of that makes a big, pushes a lot of accountability. So if a clinical team has not stopped an antibiotic on your advice, you can always, we have a lot of audits. I will speak about it later. I had a couple of interactive cases, but because we've already discussed it in Dr. Sumit's presentation, etc. in the morning, I will not go through all of them, but like Sir said, we need a lot of biofire, we need a lot of automation. So once we have a gram-positive cocci in our blood culture, within 2 hours, we know whether it is an MRSA, an MSSA, or just a coagulase-negative staph. In those 2 hours, the clinical microbiologist has to work up the patient very well, know all the clinical details while the PCR is still going on. Here we have a very bifurcated team. So the lab is handled by biomedical scientists, and we do only the clinical part here. So in that part, we try to assess if the patient actually needs antibiotics. We review the sources from where the bug might be coming in. We have online platforms which are used now more because of COVID, but we get the vitals, we get the X-rays, the MRIs, the CT scans. So we have to holistically understand what's going on with the patient. We are also allowed to book echoes, MRIs, anything that we think where the bug might be coming in from. And we have a lot of IVDU patients here. So there is a lot of infective endocarditis. We have to look for pacemakers, PICC lines. Basically, the complete assessment of the patient is done within those 2 hours of the PCR. And then accordingly, I will not discuss the slide in detail because we already know how to handle it, but we go for the with the smallest antibiotics. So fortunately for us, a lot of patients, if indicated, can be started on something as simple as fluclox. Again, this case, almost something very similar was discussed by Dr. Sumit earlier this morning, but I'm just in this slides, I just wanted to say how all of our trusts have antimicrobial guidelines depending upon the antibiogram of your hospital. So it's a very continuous process of there's a very good integration and very good surveillance systems, because of which over the last 20 years, they have kind of, they know the best antibiotics to give for a certain infection. So if for a person of sepsis of unknown origin, we start with something as simple as amoxicillin and metronidazole. But again, once we have a gram-negative bacilli in a blood culture, we need to assess the source. So if the gentleman could have a CT abdomen shows multiple gallstones, we have to review the CT. We have to optimize therapy so that we are covering the intra-abdominal source as well. And so I had all these interactive polls, but in the interest of time, I will just move forward. But we, in an 85-year-old gentleman with a possible history of past antimicrobial use, we would escalate the treatment to, say, tazocin until we have the sensitivities and the culture and sensitivities available. And we, before prescribing, you as a microbiologist in the UK, you are the first prescriber of antibiotics, and you have to consider everything, including the antibiotic allergies, which is a very, very big part of prescribing here. And once we have the sensitivities and we know the source clearly is an abdominal source, not a respiratory source or other sources, we can go as low as amoxicillin with, of course, with some anaerobic cover. So the switch from a broad spectrum to a narrow spectrum is very fast. Like Dr. Mithul Patel said, we have guidelines for how fast we need to switch antibiotics from a broad spectrum to a narrow spectrum, how fast we need to go from IV to an oral switch. So luckily for us in England, we have everything in guidelines. Now, what is the role of a clinical microbiologist in integrating all these practices in the UK? All of us have spoken about diagnostic stewardship and antibiotic stewardship. We treat the patient, not the specimen. Our role is very, very clinical. If we decide that the patient does not require antibiotics, nobody, of course, it is always a concerted decision between a lot of teams. But the microbiologist has a very big role in deciding the antibiotic therapy of the patient. Our interpretative comments, they take a very big part of our day because they're extremely tailor-made for every patient, for every bug, for every antibiotic combination. And a very big part of our interpretative comments are also infection prevention requirements. So if a patient would say an MRSA requires infection prevention, needs a side room, it's the role of the microbiologist to actively go to the infection prevention team, to go to the ward and ensure that the patient does not spread the bug to others. As I said, the microbiologist is the first prescriber of antibiotics. We have to take into account whether antibiotics are required. We've been talking about this over the last 2 days. Any antibiotic allergies, if we can just do a source control, so if we just take out the line of the patient and that is okay, or if there is a patient with a long-term catheter and we just give him stat gentamicin and take out the catheter and he does well after that, we do not require more antibiotics for him. And we work alongside the antimicrobial pharmacist, keeping in mind the body weight, the kidney and the liver functions of the patient to decide what antibiotic to put him on. In England, we avoid all C. diffogenic agents as much as possible. So we hardly use cephalosporins, we hardly use ciprofloxacin unless it's a pseudomonas needing oral therapy. And the underlying concept followed in the UK is start smart. So you start with a really broad cover if required, and then focus immediately. And there has to be a clinical review between 48 to 72 hours in which you either stop the antibiotic, you IVOST. IVOST meaning IV to oral switch as soon as possible. OPAT is a very big, it's a whole different arm of community stewardship, which I am not going to discuss today. And every decision has to be documented. So if I need to look at the records of what happened to a 98-year-old female, I will have all the records of her previous admissions over the previous years. When we go for rounds, we have this fluorescent sticker, or you can even write it down. But every time you review an antibiotic, you have to write the indication, you have to write a stop and start it. I saw all the programs today and everybody is, I'm very happy they are putting stop dates on their antibiotics. You have to do an IV to oral switch as soon as possible. And if you're writing a prescription for more than 7 days, even prescription writing comes under the fora of a microbiologist. And even that has a whole set of guidelines. If any antibiotic is continued beyond 7 days, that has to be documented with reason. The name of the pharmacist, the name of the microbiologist with the GMC number has to be given. Our ward rounds are, okay, I'm just finishing. Our ward rounds are multidisciplinary. They're always led by the microbiologist along with the clinical specialties and antimicrobial pharmacist, etc. So we have C. difficile ward rounds, we have antimicrobial ward rounds, and we have ITU ward rounds every day. Infection prevention, I already said, as soon as I authorize an alert report, it goes to the infection prevention team. I have to call up the ward to ensure that the patient is in a side room. So the PHE, the Public Health England, we have to notify, we have to either call or email the PHE for anything, any concerning for an MRSA, for a strep pneumo in the CSF, etc. So they track, they try to culture, they try to genotype, sequence everything so that they have a record of what's going on with every bug in the country. We have frequent audits, we have daily audits and monthly audits, and we've already seen examples of very good audits today. So we have to write which drug, the route of the drug, who did it along with the GMC number. Was there a valid indication? Was there a stop date mentioned? So all of that, and it is, everybody is very scared of audits. So they try to do things as perfectly as possible. We also have targets, which plays a very, very important role because we have incentives. So my trust, suppose, is allowed to have only 30 C. diff cases a year. If I overshoot it, I will be penalized for it. My trust will be penalized. Similarly, we have a zero tolerance for MRSA bacteremias and E. coli bacteremias for about, say, 100 cases only. The very good part is here in England for the last couple of years, One Health has been integrated. So not even your chickens are allowed to have colistin in this country. It is so, and the results have actually shown up. So since 2017, not a single poultry farm has used something like a ciprofloxacin or a polymyxin B. And we all know how important One Health is. They've also incentivized new antibiotic development, and they have incentives for good antibiotic practice now. So I think the UK has a very, very integrated AMSP umbrella, and we have a clinical lead and an AMSP lead. But as a microbiologist, every single day of your life, every single procedure you take is somehow related to AMSP. This is the reference that I used. It is available open access online. And yes, my trust did get the best in the NHS because it fulfilled a lot of its targets and had outstanding patient care. And we had, I think we had only 2 extra E. coli bacteremias. And this is the new me talking to the old me every time I try to prescribe a wrong antibiotic or I try to use something like a ciprofloxacin here. Are these practices reproducible in India? Why not? If someone like our mentor, Dr. Sumit, like a one-man standing army without an antimicrobial pharmacist has completely changed antimicrobial prescribing in India, why not us? Thank you very much. Any questions I'm ready to take?
Any questions? Thank you, Dr. Isha. No questions on the side. Message was clear and experience well shared. Thank you.
Thank you.
So with that, we come to the end of the experience sharing session. Thank you.
Thank you, sir.
Thank you.
We now request our chairperson, Dr. Anup, sir, to hand over the memento to Dr. Ritin Mohindra. I request you to receive the memento on behalf of Dr. Anupam. I request Dr. Prasanna Kumar Panda to come up on stage and receive the memento. Sir, I request you to receive the memento on behalf of Dr. Gaurav Chikara, Dr. Santosh Kumar, Dr. Amber Prasad, and Dr. Aki Mishra. I request Dr. Akshata to come up on stage and receive the memento. Ma'am, I request you to receive the memento on behalf of Dr. Jagdish Goyal. I request Pratyusha ma'am to give the memento to our chairperson. I request Dr. Akshata R to come up on stage and receive the memento. I think she's not here. I request Dr. Prashant to receive the memento. I request you to, sir, I request you to receive the memento on behalf of Dr. Anupam Dev. I request Dr. Prasanna Kumar Panda to come up on stage and receive the memento. Sir, I request you to receive the memento on behalf of Dr. Gaurav Chikara, Dr. Santosh Kumar, Dr. Amber Prasad, and Dr. Rakhi Mishra. I request Dr. Bhaskar Thakuria, sir, to present the memento to our chairperson, Dr. Anup, sir. I request Pratyusha ma'am to give the memento to our chairperson.